Okay, I think we can start. Welcome everyone on behalf of the Secretariat at WHO, Annemieke and myself, Sabine, Raquel. I'm welcoming you all to this virtual edition of the annual meeting of the Child and Adolescent TB Working Group. We're very happy that we have had so many colleagues registering for this for the meeting. We've had over 250 registrations. We have a very wide range of topics related to child and adolescent TB for the meeting on the agenda, from very important research updates to developments around the diagnosis of TB in children, systematic reviews on the risk of TB after exposure, as well as TB screening, and also on the impact of COVID-19 on child and adolescent TB services. We are very excited to have the director of the WHO Global TB Program with us to open the meeting. And I would therefore like to hand over to Dr. Teresa Kasaeva to give us her opening remarks. Over to you, Teresa.
Warm greetings, dear colleagues. I'm sorry, I'm struggling with my video. Seems something wrong with it. I can't share. Probably it will come later. But anyway, I'm very happy to see your faces, and I see Malgosha. It's a special gift for me, I guess. So warm greetings to all of you. So let's start. I know that you have very rich agenda, that you all are very busy people, but you've prioritized this meeting in your agendas. It's extremely important and inspiring. Thank you once again very much. This meeting happens just one day after a launch of our global TB report, and I'm happy that we succeeded in time. Now you have the full picture, and you can discuss and see where we are with the progress according to our commitments, high-level commitments, according to our roadmap for children and adolescents. Are we on track? What could be done in addition? And if to summarize in general our current situation and progress to date, we must say that for the last 2 years of the high-level meeting, we all together, we've managed to push to accelerate progress. And I would like to thank you for all your efforts, for all your hard work. This is actually a result of your work personally and the result of the whole community. Unfortunately, the whole life divided now into two parts: before COVID and now during COVID. We don't know how long it will continue, but this is our new reality. We should manage to live with this reality and to think how we can do our best to provide continuation of the essential TB services, first of all, for children. So the progress in few numbers is towards 2020 milestones. We've decreased TB incidence by 9%. We've decreased TB mortality by 14%, and of course, it's not enough. According to the UN high-level meeting targets, 40 million, and which should be provided by treatment for 5 years, and 30 million by preventive treatment. Big numbers. 14.1 for 2 years received access to the treatment and care, and 6.3 million people were provided by preventive treatment. If we will look at the situation for children and the proportion of children among other falling ill last year increased. Is 1.2 million children fell ill, and it means that around 1 million children were treated for the last 2 years. It's 30% of our 3.5 million target for children. So when we are looking at the data for children with MDR-TB, around 9,000 children were treated for MDR-TB for the same 2 years, and it's 8% of the 5-year target of 115,000. Progress is very modest, unfortunately. If we will now move to the preventive treatment coverage, the progress is really very impressive, and especially in the preventive treatment for people living with HIV. We have 6 million target, I would remind you, for 5 years, and this year the target, it was 5.3 million people with HIV were already reached. This is 6 million for people with HIV. Excellent progress. Now, if we'll go further and look at the situation with the children under 5 years old who were household contacts of people with TB, only 20% of the 5-year target of 4 million were reached, around 800,000 children. And situation with other household contacts is really even worse. Less than 200,000, which is less than 1% of the 5-year target of 20 million. We are moving forward. It's not easy, but it's possible. We can see, according to this progress done for children, especially children under 5 years old. And once again, I would like to thank you all. Of course, now this situation with the COVID-19 affected badly all the countries, all the systems, and of course TB programs. We are monitoring on a regular basis information from we are receiving from regional offices and country offices, and it's very threatening, because all countries are reporting disruption of services due to different reasons. And based on our modeling, if drop in notification up to 50% will be continued for more than 3 months, we can unfortunately predict up to 400,000 additional deaths due to TB already this year. And we should try to do our best to avoid this situation. So this is briefly about where we are. And I think that this meeting is absolutely timely, and it's excellent opportunity to revise our situation in details, to share different experiences. I hope also positive experiences will be shared, and to brainstorm how we should move further. You know that WHO, according to its core function, is working on the development of policies, guidelines, which are now under the category of global goods. And the development of the guidelines for treatment of children with TB and diagnosis is among the top priorities and nearest priorities for the global TB program. We all know our gaps, our challenges with the evidence, but there is no other way, neither move forward and to move the whole agenda. I hope that this meeting will be a really very important contribution and a step forward towards our aim to provide better treatment, easier, safer treatment options for all children, to provide preventive treatment. We have much more opportunities for this, but how to make it usable and applicable for all, at least high TB burden countries, is also a question for all of us. So I would like to stop with this, and I will try to spend as much time as possible with you, and with huge interest will listen to your questions. Thank you.
Hello, everyone, and thank you very much, Teresa, for that for that lovely introduction and for all your support and all the support of the Global TB program in for us for working for children and adolescents with TB. We really would not be anywhere without your support. So welcome everyone, and thank you for joining our 17th annual virtual Child and Adolescent TB Working Group group meeting. We are up to 104 participants right now, which is fantastic. And a big shout out to Malgosia Gremska. Thank you for being with us. Again, we wouldn't be anywhere without Malgosia's efforts. I mean, she's literally from 2011 down to 2020, I think whatever we are has really been built by the Secretariat's efforts and by Malgosia's efforts, and we thank you for that. So I think a few housekeeping details before I launch into my presentation. So essentially today's meeting is divided into two sessions of 2.5 hours each. With a 1 hour break at 12:30, hopefully, if we stay on time, Central European time. And then it's open to all the members of the working group, and the Secretariat is recording the sessions, and they will be available to all of those people who are on these, ends of the time zones and are not able to attend certain sessions. So fabulous. Apologies, I didn't hear that.
Still, we thought it will be a one-time and it was the randomization event here because the logical randomization in the brain. If we'll
Dr. Anna, could you kindly speak your screen, please?
Then yeah, it can be fully randomized. But since we are not randomized.
Sorry, I've just muted everyone so that Farhana can speak. Farhana, please unmute and go ahead. Sorry about that.
Okay. Sorry about that. I'm trying to.
We can see your screen, but perhaps you can.
I can just expand it. Sorry, just 1 minute. And here we go. Okay, am I unmuted? No. Okay. Can you hear me? Okay, super. All right. So, so I would like to begin my presentation. Essentially, I will walk you through an update for our working group. Essentially, all the activities and work that has been done since 2019 and 2020, pretty much since our last meeting that was held last year. And here we go. So I will go over the progress since the UNHLM on tuberculosis that was held in 2018, as you guys remember. All the activities and the meetings and coordination that has taken place since, the webinars that have been conducted on TB, as well as the impact of COVID-19 on child and adolescent TB, and what is the landscape looking like for the coming year. So to start with, as you guys remember from the 2018 UNHLM, on the wings of that, we were fortunate to have the launch of the roadmap for child and adolescent TB, which has facilitated countries in the development of their TB plans for children and adolescents. The Russian translation for that was completed in December, and then the Spanish translation was completed in May of 2020, and it is available online at this link. we had a meeting on ending TB in children and adolescents that was held in Hanoi in Vietnam last year in November, end of November. This was a regional consultation for the Eastern Mediterranean region, the Southeast Asian region, and the Western Pacific regions. And it was a very fruitful meeting that was graciously hosted by the government of Vietnam, and with active participation from the national program. We had over 100 participants from 12 countries. The great thing was that the countries presented their child and adolescent TB landscapes, and then also presented contextual solutions to the issues that they face. And then were facilitated by members from our working group and the core team in further developing and chalking out their country action plans based on based on the current guidance at that time. And these were reflected, we hope, in the national strategic plans, as well as it was a timely exercise just before the countries were preparing their funding requests and their global fund applications to reflect the specific needs of children and adolescents in their requests. Next, we had the UNGA HLM TB progress report, which included a section on ending TB in children and adolescents. And that was developed again by the Secretariat with inputs from the core team. A very important thing that happened is which is now reflected on the WHO Global TB report that 2020 was the expansion of data that is reported on children and adolescents. You know that we don't currently do not have data from all the countries. It's reported in 0 to 5 and then 5 to 14. But this included data from countries who were recording data digitally, and it includes the missing adolescent piece from 10 to 19 years. So it gives us a very good idea of what the adolescent burden of tuberculosis really is from some of the high burden settings. So this is an excellent thing, and it will be further elaborated on by Sabina and Anamika. And then we also found out about the MDR and RIF-resistant TB numbers for children, which were essentially not properly reported in the past, and outcomes of TB, which is again a new addition, considering that children just started getting reported in the Global TB report in 2012. This is landmark event. What other progress is, so I'd like to report that national TB program reviews happened till they could happen within the country context with pediatric TB experts. Now, these reviews are actually extremely important because this is the one opportunity for countries to really get inputs from experts and from recommendations from technical partners, and if to have pediatric TB representation on the program reviews is really it's very, very important, and then it gets reflected on and prioritized within their national strategic plans and hopefully within their global fund applications and the budgets and whatnot. So this, we had pediatric representation in the India NTP review in November of 2019, South Africa, in Indonesia in January of this year, Tanzania in February, Zambia and Sierra Leone till March. I think since then, there really hasn't been, unfortunately, an opportunity for an in-country review given COVID, and of course such reviews and evaluations really need to happen on the ground where you actually do the go to the sites and see what's happening on the ground. So they unfortunately cannot be conducted virtually. Then we go on to the orientation of what's new in TB and engagement with the Global Fund. So this was a very important exercise that occurred in January of 2020, where there was a session on pediatric TB and the budgeting tools were introduced. Again, the budgeting tools will be phenomenal to be actually implemented and to be used to have proper line items with asks for children in funding request budgets. This would be really instrumental, and we hope that it was still a sort of in the nascent phase, I believe, when COVID happened. So the team has plans of sending the budgeting tools and making sure that countries do use them, and it is reflected in at least in the next year's funding requests. And then the program review form was translated into. Oops, I'm not really seeing my slides here. Was translated into French, I believe, for the union. And then, of course, the guidelines on the management of TB and in children and adolescents need to be updated, and work is ongoing for that. There was a consultation with the core team of the working group regarding what topics need to be covered, and there was a call for data that was sent out after we got inputs it was issued in July of 2020, and there has been good feedback from that, from what I hear, and there will be more details provided in the WHO update upcoming. So essentially, the activities further update is that there's our partners, including EdPAF, UNICEF, CDC, TAG, Stop TB Partnership, and of course the WHO, set up the Pediatric Operational Sustainable Expertise Exchange, which is also known as the POSSE group. That is the mandate is to ensure sustainability of interventions in the UNITAID funded CAP TB project. Again, a very valuable exercise to support countries with their NSP development and global fund applications. And the budgeting tools have been finalized and widely disseminated through the WHO Global TB and Global Fund. And the POSSE is now a task force under the Child and Adolescent TB Working Group, and a very important and sort of like an action-oriented addition to the working group. I represented the implementation working groups in the 32nd Stop TB Partnership board meeting that was held in Jakarta of last year. This was my first time attending the board meeting, and I was essentially representing the implementation working groups, which includes other groups like the on drugs, PPM, etc., and of course our child and adolescent TB working group. This year, since it'll be a virtual meeting, so it is a wonderful opportunity for other members that have the list of which we have already, who will be able to participate, and not participate, but at least attend the board meeting and see what the proceedings are. And this will be, I think, really, really interesting to see how that goes. And then we have the very important exercise of review of the Global Fund applications from high burden countries and priority countries, to see if they have, so how children are prioritizing them, to see what interventions for TB prevention, diagnosis, screening, treatment, and care are within the Global Fund applications. As you know, that is the main crux of the funding that for TB in most high burden countries. The Secretariat and the core team members were involved in those reviews, and they have been really instrumental in sort of helping align align some of the needs of children and making sure that they're there. And of course, I joined the joined the technical review panel of the Global Fund, so that, and I'm happy to report, and this is my first year doing that, and I'm happy to report that the TB experts and the human rights and gender specialists and experts that we have on the TRP are all very supportive and help review the funding requests from a pediatric and an adolescent lens, which is really fantastic to see, and that's progress. And let's see. Okay, so we of course had our annual meeting of the working group in Hyderabad last year. And then we've had core team calls which have again been fantastic discussions and rich updates from countries that, as everyone has struggled, particularly as everyone has struggled with COVID-19. And then we had our PADO, which is the Pediatric Anti-TB Drug Optimization meeting, which is again a review this time, follow on to the PADO TB1 that was held in February of 2019. A fantastic meeting. We got updates on pediatric medicines and formulation. We heard about the current the studies and outcomes and data. There were discussions and consensus on shifting in priorities for both drug-sensitive and drug-resistant TB, as well as the TB preventive therapy and LTBI treatment. So more on that later. And the core team and the secretariat are on the advisory committee for the Center of Excellence. And the HIV implementation working group has a call on pediatric HIV, had a call rather, in May of 2020. This was attended by Martina Kisengi, James Seddon, and Sabina Mercury. So a lot has happened despite the fact that it's been a pretty crazy year. And then we had the webinar between the Union and SSA Center of Excellence webinar on the programmatic management of children and adolescents with TB in the initial COVID-19 response. That was in June of 2020. And we had, obviously that was very well received, and following that, there was the Child and Adolescent TB Working Group, and the Union hosted Maintaining Essential Child and Adolescent TB Services During COVID-19 Pandemic, sort of a practical solutions-oriented and lessons learned oriented webinar that was, again, well attended and with excellent speakers, including Shakil, Celia, Satish Kumar, and Trishala Chabala. And we also saw for the first time this wonderful video that really kind of illustrates how COVID-19 has affected TB services, and what, although negatively in many ways, but how this has also been an opportunity for change and perhaps even improvement as we go on. I missed the Warren and Karn network on COVID and childhood TB in June of 2020, where Dennis and Sabina spoke. And again, looking at opportunities really that are going to come out of the COVID pandemic specific for children with TB. And then we go to all our planned activities for the coming year. So the regional meeting in the African region is really with the focus on the implementation and the roadmap actions, really depends on what is going to happen with the COVID-19 situation, and is yet to be determined when that will happen. There will be ongoing work on the update of the child and adolescent guidelines, which we hope to be released end of 2021. This is again a long time coming. It's, as you know, countries. A lot has happened since, several updates. The great thing is that along with the guidelines, there's also an operational handbook on management of child and adolescent TB that is really, countries are will be very, very happy to have. Programs will be happy to have with practical implementation and programmatic guidance. So that will be that is something to look forward to by the end of the year. And development of updated training for child and adolescent TB, which will be in line with the guidelines, the handbook in collaboration with the union. There will be the follow-up PADO meeting, the PADO 2, and the high-level dialogue on pediatric TB and in children living with HIV in the Vatican in early November, later on this year. Continue to highlight challenges and opportunities in all the relevant fora and promote research and development. And we will continue to obviously organize our annual meeting with the Child and Adolescent TB Working Group with regional engagement of all relevant stakeholders, and assist countries to move from single projects to programmatic approaches, and really kind of take the child TB and sort of prioritize it, and adolescent TB, and put it on the map for these countries. So with that, I would like to acknowledge and give a big shout out to Annemieke Brands and Sabine Werkwie for all the fantastic work that they do. And it is essentially all the heavy lifting, all the work is done by these two. And we just show up to meetings. But thank you so much. And again, Malgosia, we are really sitting on all the laurels that you have gathered. And of course, thanks to our core team members, the implementation partners, funding agencies, researchers, the PADO participants, NTPs, pediatricians, healthcare workers, all the community volunteers, child TB advocates, and not to forget all the children affected by TB and the families affected by TB, who are our real teachers and trainers in this fight or that we have against TB. So thank you very much for listening in to our updates. And with that, I would like to introduce to you a lovely little video from our colleagues in Brazil. They have developed a 3-minute video, and it really illustrates it highlights the experience of a family affected by TB in the times of COVID. So let's begin.
Apologies for the problem with the apologies for the problem with the sound. Luckily, there was subtitles and text all the way. Apologies, and thanks very much to our colleagues from Brazil.
Yes, sorry about that. I think the sound didn't come through, but the images you could see and the text you could see, and it was again a situation where a problem was essentially turned into an opportunity for, although the child got affected and then presented later on, and if they had presented earlier, if they hadn't been COVID and he would have gotten TPT, he wouldn't have had TB and wouldn't have had to had treatment for it. But the COVID situation also changed how services were managed, and it became an opportunity. So okay, so without further ado, I would like to invite our secretariat, Sabina and Anamika, to present the WHO update on new policy recommendations and progress towards the UNGA HLM on TB targets. Over to you guys. Thank you.
Thank you very much, Farhana. Also, thank you very much, Teresa, and also apologies to Bettina and Andrea for this technical issue with the sound. Perhaps we have an opportunity later today to show the video again. And let me also take the opportunity to thank USAID very warmly for the continued support that we are receiving for the functioning of this working group. And before I'll try to run through the presentation in half the time as we had, let me also warmly welcome Dr. Farai Mafhunga. Dr. Farai Mafhunga took office on Monday and is leading the unit within the Global TB Program on TB vulnerable populations, communities, and comorbidities. So a very warm welcome to Dr. Farai. Next slide, please. Sabine and I would give you today an overview of the data on children and adolescents as included in the Global TB Report 2020. We will mention, like Teresa already did a little bit in her openings address, progress towards the UN high-level meeting targets related to children. And we will give you a brief policy update of policies that came out since the last time we met. And we will lay out a little bit the process of updating the 2014 childhood TB guidelines that we have embarked on. Of course, we will also quickly address the impact of COVID-19. Next slide, please. So what is new in the Global TB Report 2020 is that countries with electronic case-based systems were requested to report in age bands 0 to 4, 5 to 9, 10 to 14, and 50 to 19. Also, other countries were requested to do so, and we hope that in the future they will be able to give those data to us. Treatment initiation for children with multi-drug resistant TB or rifampicin resistant TB and young adolescents 0 to 14 years have been requested, and countries who did report on treatment outcomes in children under 15, which is mainly treatment success rate. And we have included a box on strengthening data collection for children and adolescents with TB in chapter 5 of the report, which is on page 89 and 91. And we have shared with you the link of the report, I think in an email yesterday. Next slide, please. So this slide shows the infographics from the 2018 roadmap, now updated with the data as included in the Global TB Report 2020. The estimated incidence of TB in children under 15 years has increased to almost 1.2 million in 2019. Mortality has increased compared to last year's estimates, although because of methodology issues, you cannot really directly compare. But we estimated that in 2019, 230,000 children have died of TB. This including 36,000 children who were living with HIV. This means that children make up over 16% of all TB deaths, whereas the proportion is 12% of the burden. Estimates for adolescents are not yet available this year. With more notification available for this age group, it is hoped that more detailed age disaggregation estimates can be done for next year's report. Next slide, please. So 95 countries were able to report data disaggregated by age, including 10 TB high burden countries listed here in this slide. These 10 TB high burden countries represent almost 45% of all notifications in the age group under 15 years. This is the first time we have notification data for adolescent age groups from 10 to 19 years. The so-called spaghetti graph on the right of the slide is from box 5.3 of the Global TB Report and shows the notification rates for the 5-year age groups, showing a wide variety of rates for different age groups, with almost all countries relatively high rates in older adolescents. The proportion among all notifications of each age groups are largely in line with the estimates published by Catherine Snow and all in 2018. Next slide, please. So in terms of treatment initiation for children with multi-drug resistant or rifampicin resistant TB below the age of 15 who initiated second-line treatment, data were reported for 2018 and 2019. In 165 countries reported at least one child started on second-line treatment in 2019. And 6 countries listed here, India, Russian Federation, South Africa, Ukraine, Pakistan, and Kazakhstan, reported 100 or more children who started on second-line treatment. These 6 countries are covering 81% of all cases in 2019. India reported the highest number, representing over 60% of all children reported. In 2019, just over 3% of all people started on second-line treatment were children, although up from 2% in 2018. Compared to the estimated annual burden as modeled by Pete Dodd and Helen Jenkins, over 17% of children with drug-resistant TB were detected in 2019. Although this is better than the 4% estimated previously, it's still very far from finding all these children, and it's not yet a success. Next slide, please. Lastly, the countries were requested to report on treatment outcomes in children aged below 15 years. 123 of 215 countries reporting were able to report on the treatment success rate, including 19 of the 30 TB high-burden countries. The total cohort size was almost 350,000 children, representing 2/3 of the total notifications in children aged 15 years in 2018 for these 19 high-burden countries. The overall success rate was 85% in these 19 high-burden countries, ranging from 73% in Papua New Guinea to 97% in Bangladesh. 2 regions, the European region and the Americas, reported all treatment outcomes for children. 99 countries in these regions reported for a total cohort of over 13,000 children. The success rate was similar, 84%, but there was a relatively high percentage of children that were not evaluated, almost 10% versus 6% in adults overall. This warrants a detailed root cause analysis to evaluate what happened to these children. Next slide, please. This graph shows the trend in the provision of TB preventive treatment to household contacts under the age of 5 who are eligible for TB preventive treatment. There has been a steady but slow increase in the proportion of eligible contacts receiving TB preventive treatment, from 7% in 2015 to 33% in 2019. So about 1 in 3 eligible children under 5 are receiving TB preventive treatment. Next slide, please. In summary, the huge case detection and prevention gaps remain and need to be addressed as a matter of urgency. The case detection gap is around 56% for all children under 15 years, but it is as large as 65% for children under 5. 2/3 of, as I said, 2/3 of eligible children under 5 years do not receive TB preventive treatment and run the risk of getting sick with TB. Next slide, please. So this slide summarizes progress against the child-specific targets of the HLM on TB. It shows where we currently stand in the period between 2018 and 2022. So after 2 years, 2018 and 2019, we should be at more or less 40% of reaching each of the targets. But as you see, we've used the color code. In red, it's percentages up to 25% of the 2022 target. In green, over 40% of the 2022 target, and in orange, only 25 to 35% of the 2022 target. So for case detection, so far we've only achieved 30% of children notified with TB. In terms of children started or second-line treatment, out of the 115,000 to be reached by 2022, so far we've only reached 7.8% of them. And in terms of TB preventive treatment, only 20% of the 2022 target of 4 million children contacts below 5 initiated on TPT have been achieved so far, and only 0.9% of children 5 years and above of the target. Where we are doing rather well is on providing TB preventive treatment to people living with HIV. Here we are at 88% of the 5-year target, including children living with HIV. So with having said that, I would like to hand over to Sabine, who will quickly give you some updates on the recent policy guidance. Thank you.
Thanks very much, Annemieke, for that great overview. And we really feel that this is an important milestone, have these additional data available around outcomes and children with started on second-line treatment data that were previously not available. So at least we know better, but we also know better that we're not doing that well. So there's a lot that needs to happen. I will just give you a quick overview, if my slides want to move now at least, of some policy updates that have recently come out that are relevant for children and adolescents. So firstly, the TB Preventive Treatment Guidelines and Handbook, which were published around World TB Day this year, which highlight different alternative options for provision of TB preventive treatment to different populations, including the 3 months weekly rifampicin and INH regimen, as well as the 3 months daily isoniazid and rifampicin regimen, and also the 4 months daily rifampicin and 1 month weekly 1 month daily rifampicin and INH. So the regimens that are listed here in bold have strong recommendations, while the others, 4R and 1HP, are still conditional recommendations. The choice of regimens obviously will depend on the availability of appropriate formulations, and that's very important for children, and considerations for age, safety, drug-drug interactions, and adherence. Currently, the age limits for the 3HP regimen is for children over the age of 2 and for 1HP over the age of 13. And studies are still ongoing, and we will hear a little bit more about that today on the use of these regimens in the younger children. And then important to note that pregnancy does not disqualify women living with HIV from receiving IPT. That was a specific PICO question that was addressed in this guideline update, but more research is needed for on this, but automatic deferral of IPT to the postpartum period may not be justified. There are also no grounds to support dose changes when rifampicin is used together with dolutegravir in adults living with HIV. Whereas we know that the dose does need to be adjusted when given with rifampicin in adults, and data on children are still awaited. Just a quick of regimens to use in different situations. And in terms of time, I will not go into too much detail, but the preferred regimen for young children is really the 3RH regimen, using the available 2 FDC, rifampicin and INH, which is a dispersible formulation, which is now available in more than 93 countries all over the world, mainly through GDF. For children living with HIV, in most cases, the 6 months regimen of INH is still the best one to use, especially in children on ART. also have new guidelines and a new handbook, operational handbook on rapid diagnostics for TB detection. This guideline came out in June, where there are strong recommendations on the use of expert MTB-RIF in children with signs and symptoms of pulmonary TB as initial diagnostic tests, as well as for rifampicin resistance detection, not only in sputum and gastric aspirate, but also now in nasopharyngeal aspirates and in stool specimens. So for the childhood TB community, this is quite another milestone where we can use the most child-friendly specimens, including stool. And so it will be important to look at how this can be widely implemented. And we will hear some initial experiences from our colleagues from KNCV in implementing stool testing today, as well as from our colleagues from the TB Speed project in using stool in the TB in the project implemented in different African countries and Cambodia. There is also strong recommendation of the use of expert ultra, but this could also only be evaluated in sputum or nasopharyngeal aspirate. And then there's a strong recommendation for the use of expert or ultra in cerebrospinal fluid for the diagnosis of TB meningitis. There are conditional recommendations on the use of various specimens for extrapulmonary TB diagnosis, as conditional recommendations on repeat testing using expert or expert ultra. Now, these recommendations are related to the pretest probability. So in low pretest probabilities, testing is not recommended. To repeating the test is not recommended. In settings with a higher pretest probability, expert or ultra can be repeated on the same specimens as the original recommendation. Now, this of course has some implications for operational guidance, and that is something where technical assistance will be needed in order for people on the ground to really understand what this means and how it is to be implemented. The recommendations on LF-LAM in children and adolescents living with HIV that were originally included in a 2019 policy update, they have now also been integrated in the Rapid Diagnostics guidelines. So there's a strong recommendation to use LF-LAM to assist in the diagnosis of active TB in HIV-positive children and adolescents. And you see there all the different requirements or conditions that need to be met there. There are algorithms for both inpatient and outpatient settings. Important to note that the use of LF-LAM has really been recommended in conjunction with the use of expert or expert ultra. I'm sorry, I'm going a little bit fast because I'm looking at the time and I don't want to run too much behind. The other important guideline update that also came out in June is the drug-resistant TB guideline, which recommends a shorter all-oral bedaquiline-containing regimen for eligible patients. That includes patients who do not have extensive TB disease and do not have severe forms of extrapulmonary TB, which means any forms of extrapulmonary TB other than TB lymphadenopathy. And that is also recommended in children over the age of 6. The guidelines state that child-friendly formulations should be used whenever possible. There's also reference to the bedaquiline crush study, which showed that there is a good bioavailability when you crush bedaquiline tablets and dissolve them in water. So that's important for children. At the same time, we now have seen FDA approval of the bedaquiline dispersible formula or the pediatric formulation, 20 milligrams, which has been approved for children over the age of 5, although these data have not yet been assessed by WHO. But this formulation is now also available through GDF and will make it easier for countries to implement these shorter regimens for children. Longer individualized regimens are still needed for those, including children who are not eligible for the shorter regimen. And that, of course, will include children below the age of 6 and those with more severe forms of extrapulmonary TB. The laminate can be used in children over the age of 3 or 3 and over. And the duration of treatment can be shortened to less than 18 months in children without extensive TB disease. And then there's the BPAL regimen, which is recommended conditionally to be used under operational research conditions in patients over the age of 14 years who have MDR TB with additional quinolone resistance. So there's also here an operational handbook that has more practical guidance on how to implement these recommendations. As Farhana was already mentioning, we have started the process of updating the 2014 Child TB guidelines. The target audience will really be expanded beyond national TB programs. We're also expanding to include adolescents aged 10 to 19 years old. There will be a consolidated document to include new recommendations based on new reviews of evidence. But of course, all these relevant recommendations from other guidelines will also be included, including from TB guidelines, but also HIV and, for example, nutrition. Again, there will be an accompanying operational handbook with practical how-to guidance on all the topics covered in the guidelines. And we are hoping to also include the grayer areas without evidence-based recommendations, more based on expert opinion. So far, we've had input from the core team of the working group on the topics to include in the call for data. The call for data was then issued in July. We received many responses and categorized those, and the scope that is now emerging focuses on treatment shortening in children with non-severe TB, and we will hear some data, the data from the SHINE trial today. Also diagnostic approaches in children with and without comorbidities, treatment of children with drug-resistant TB with all oral regimens, and then also models of care for the delivery of TB prevention, case detection, treatment and care. We are still in the process of reviewing the data on other topics, for example, treatment of congenital TB and TB in infants, as well as severe forms of TB. So that could possibly be included, but we are in the process of looking at more data for that. We had, in the meantime, our first internal steering group meeting, and the next steps will really be to finalize the scope of the guideline and the PICO questions, then commission the systematic reviews, establish a guideline development group. And as Farhana was saying, the target date for publication is the end of next year. And of course, a lot of the timing will depend on how quickly the process can move in these times of COVID. Speaking about COVID, of course, we've seen a huge impact COVID on child and adolescent TB services, and at the end of the day, there will be a specific session on this, where we hear from colleagues all over the world how big this impact has been. Some of the issues that we've seen is the isolation of children with features of respiratory infection, the lockdowns, the closed TB facilities, staff being reassigned, leading to delays in TB diagnosis and initiation of treatment. Also, of course, leading to increased household exposure of children to TB. At the same time, competing needs for the diagnosis of both COVID and TB, for example, the gene expert test using the same platform. And there are also a lot of indirect impacts, including reduced household income, increased leading to food insecurity, malnutrition, vulnerability to other diseases, children missing their health checks, missing their vaccinations. And you can see there are quite a number of dots there. There may be a whole lot of other issues, and we hope to hear from our colleagues which ones they are and how they've dealt with them. A number of WHO publications have been issued, including an information note on TB and COVID, a question and answers on TB and COVID, also a scientific brief on BCG and COVID, and operational guidance on maintaining essential health services. The links are in this presentation if you want to get more information there. That brings me to the end of this presentation. I would really like to acknowledge all the colleagues from the WHO Global TB Program, as well as Farhana and Ben and the core team and all the other members of the working group. Thank you so much.
Thank you very much, Sabina and Anamika, for that excellent update on the Global TB report, as well as the policy guidance from WHO. I think we can just dive straight into our next session, which is session 1B, which is the Pediatric TB Research Update, which will be chaired by Ben Murray and Steve Graham. And I think we can just launch into that. Thank you.
Yeah, thanks very much, Farhana. It's Steve. Is Ben, are you there? I haven't seen Ben's name on the list, but I'm sure he'll speak up if he arrives. So can you hear me okay, Sabine? Can you hear?
Yes, perfect, Steve. Please go ahead.
Okay, great. Okay, so listen, good evening, everyone. I'm sorry not to see you all in person. I have to say that for me, the annual meeting of the Child and Adolescent TB Working Group is a real highlight. So, but anyway, it's great that we've come together, and we're a little bit delayed now, but that's a good thing because there's clearly a lot to report. And I think I'm really impressed by the improved reporting in child and adolescent TB and all the updated guidelines for detect, treat, and prevent. So that is really exciting to see. Anyway, without any further ado, I'd like to get on. We have 4 speakers and then half an hour for discussion. So I'm really keen for the speakers to keep to time, given that we're behind time. And I'd like to start by inviting Karen Dupre from Stellenbosch University and the Desmond Tutu TB Centre to talk on her work on TB meningitis. Over to you, Karen. Karen, are you there?
Hi, sorry, Steve. I struggled to unmute myself there. Can you hear me now?
Yes, we can.
Great. Thank you. And thank you very much for good morning and good afternoon and good evening to everybody today. And thank you very much for the opportunity to present a brief overview of an exciting research study that started earlier this year, and which will help us to hopefully better understand the epidemiology of childhood tuberculous meningitis. Okay. We're all very well aware of the significant burden of TB in children and adolescents globally. And I think if we look at the data from the roadmap in from 2017, the data doesn't look that different to what we've seen in the latest TB report that was launched yesterday. And we can still say that unreliable and incomplete surveillance data for children with TB currently limits our ability to appropriately prevent and manage pediatric TB. And I completely agree with Steve that seeing the age disaggregated results or data in the latest report is extremely exciting, as it's really an important first step towards better surveillance for pediatric TB and adolescents. Of the estimated 1 million children with TB globally in 2017, only 45% were reported to the World Health Organization, which is sort of a 55% reporting gap or case detection gap. So 55% of children were either undiagnosed or diagnosed but not reported. And this is partly due to the diagnostic challenges in pediatric TB, but also due to limited historical efforts to conduct TB surveillance in children. Optimal TB surveillance should also capture the full spectrum of disease in children. And young children are at high risk of disseminated forms of TB, including TB meningitis. Children with TBM suffer high morbidity and mortality and frequently permanent neurological disabilities, with poor long-term outcomes if not diagnosed and treated early. And the consequent lifelong neurological disabilities also place huge economic and social burden on families, communities, and public health services. TBM also frequently presents with non-distinct symptoms, and this results in a delayed diagnosis, advanced presentation, and severe morbidity. Early diagnosis and treatment are critical to improve the outcomes. But in high TB burden settings, children are often diagnosed late or they die undiagnosed. And all of these challenges are compounded by the lack of available surveillance data for childhood TBM. Routine TB surveillance data does not allow us to distinguish TBM from other forms of TB at present. And mortality data in resources-limited settings rarely quantify undiagnosed deaths due to TB and TBM accurately. The aim of this study is therefore to determine the burden and outcomes of TB meningitis in children at a global, national, and subnational level in South Africa, and really with the aim of identifying opportunities for prevention, earlier diagnosis, and treatment. The study consists of 3 specific aims, which will each look at the burden and outcomes of TBM in children at a different level. Firstly, globally, then nationally, and then subnationally in one health district in South Africa. And the study team consists of a large number of national and international investigators and collaborators, many whom are part of this working group, and without whose support and input, this project would not have been possible. So thank you for everybody who is involved with this. The first aim of the study is to model the global disease burden and attributable mortality of pediatric TB meningitis. Parameters of the age-related risk of disease progression to TBM following TB infection will be incorporated into an existing mathematical model to produce the first estimates of the global burden of childhood TBM by country and by WHO region. Parameters of TBM-related mortality will be used to estimate global pediatric TB mortality attributable to TBM. I think it will be very interesting to see a large proportion of deaths in the amongst young children. So 80% of the deaths in the recent report was amongst young children. And I'm wondering how many of those are possibly attributable to undiagnosed TB meningitis. The model will also consider the potential impact of HIV, BCG vaccination, and TB preventive therapy uptake on the risk of disease progression to TBM in children. And we're really hoping to be able to present some of these results already next year at the next meeting. The second aim of the study is to investigate spatial and temporal variation of reported cases of pediatric TBM in South Africa. Primary and secondary ICD-10 diagnostic codes are captured in the South African electronic TB registers. And within a cleaned and deduplicated national data set, approximately 8,500 children with TBM were diagnosed, treated, and reported between 2004 and 2017 in South Africa. We will complete ecological analyses to determine variation of case notification rates of TBM, TBM as a percentage of all childhood TB cases, the percentage favorable TB treatment outcomes, and mortality at a district level. Through these analyses, we will determine population-level drivers of high burden location and unfavorable outcomes to identify priority geographic areas in need of interventions to strengthen prevention and care of pediatric TBM. And results of these analyses will hopefully be available towards the end of next year and into 2022. Lastly, we will determine the incidence and case fatality rate of childhood TBM as accurately as possible in a single health district, the City of Cape Town, which is a well-defined geographic area with really good health systems, including a strong health surveillance unit. And we will do this through a prospective observational cohort study, which will include all children diagnosed with TBM in Cape Town over a 2-year period that will start next year. And we expect to enroll between 160 to 240 children, and all cases will be classified using the consensus TBM research case definitions. To determine the true incidence, we have to accurately identify not only all diagnosed cases, but also all undiagnosed cases. Prior to study implementation, routine health services will be strengthened through training to increase awareness of pediatric TBM amongst healthcare workers, and to also standardize diagnostic practices at all hospitals. Within Cape Town and the Western Cape Province in South Africa, the Provincial Health Data Centre combines individual electronic health surveillance data from multiple sources, including hospitals, clinics, pharmacies, laboratories, vital statistics, as well as the electronic TB registers. Using this source of data, all children with TBM in the district will be identified through diagnostic codes or investigations. And concurrently, we'll be doing clinical surveillance at the 3 hospitals where the majority of patients with TBM are managed to minimize the possibility of missing any patients. We will adopt multiple strategies to identify all undiagnosed cases, which I think is the more difficult part. And for that, we will include post-mortem data from all sudden unexpected childhood deaths, and we'll complete medical record reviews of all meningitis-related childhood deaths. We will also review vital statistics data to calculate the proportion of childhood deaths in each sub-district with meningitis of unknown cause as a cause of death in the vital statistics database. Now, given the good access to services and availability of forensic and national vital statistics data, Cape Town is really the ideal setting to conduct this type of study to establish methodological tools for epidemiological surveillance of pediatric TBM. The study will collect data on diagnostic certainty, disease severity, comorbidities, outcome, and also very importantly, missed opportunities for both TB preventive therapy or BCG vaccination and earlier diagnosis. The 2 primary outcomes are overall and stratified childhood TBM incidence and case fatality rates. But I think the exploratory analysis are really important, and that will include the development of a diagnostic checklist, which could be used to facilitate earlier diagnosis. And we will also use 3 variables: missed opportunities for prevention, TBM stage at presentation as a proxy for a late diagnosis, and the number of related healthcare visits prior to diagnosis to identify clusters, geographical clusters of poorly performing areas, which can then benefit from targeted interventions to improve TBM prevention and care. So in summary, this research will provide critical information on not only the global, but also the national burden, incidence, and related mortality of TBM in children, whilst identifying opportunities to improve prevention and care through in-depth prospective surveillance. And I would also like to invite any member of the working group or anybody else who maybe have some local data on pediatric TBM or know that their country maybe collect data on TBM to please contact me. We're really interested to hear experiences from other countries and are really open to possible wider collaboration, especially through the working group, so that we can really have a better idea of how many children are affected by TBM globally. Thank you. Thank you very much.
Thanks very much, Karen. Because of the challenges of the WebEx or Zoom, I think it might be best if people kept their questions to the end of the 4 presentations. So please put your questions into the chat, or it might be, so that we can have those at the end. But this is a really clear presentation. Thank you, on a really important topic. Even here in Melbourne, we've recently had 3 cases of TB involving the CNS in the last couple of months. Where the diagnosis is made early, the presentation is early, so the outcomes can be actually quite good, which is not the case for many settings. And so I think you've highlighted a really, really important disease associated with mortality and disability. So thank you for that. I'd like to ask, I think the next speaker will be giving us an update on the SHINE trial, which is clearly a really important update. And that this SHINE trial, I think, as you know, was done in a number of settings in Africa, in South Africa, Zambia, Uganda, but also in India. And the presentation is by Arti and Priyanka from Pune. So over to you to present the SHINE trial. Thank you.
I will share the slides for you. Oops. Can you see it?
Yes, yes, can see it clearly. Yep, yep. Thank you.
Okay, excellent. Oops. I will...
Good afternoon, everyone. I hope I'm audible. So on behalf of the SHINE trial team, myself and Dr. Kinikar will be presenting the main results of the SHINE trial, which stands for shorter treatment for minimal TB children. SHINE trial is a phase 3 randomized open label trial in which we enroll participants from Africa and India. I'll be giving a brief background of the study, including the design, population, and analysis plans. And Dr. Kinikar will present the main results of the trial. Can I have the next slide, please? Just to give a brief background, over 1 million children develop TB annually, and 2/3 of these have non-severe paucibacillary TB. These children might benefit from a shorter treatment duration. A meta-analysis of drug shortening trials in adults suggests that 4-month treatment regimes are efficacious in paucibacillary TB. And also, given the limited resources, the focus historically has been on adult trials with extrapolation of results to children, resulting in possible inappropriate treatment of pediatric TB, which is typically paucibacillary. With this background, we aim to answer the question of whether we can safely reduce 6-month treatment to 4 months in children with non-severe TB. The SHINE trial is the first pediatric phase 3 RCT, which aims to answer this question. Next slide, please. The study was designed to include 1,200 children with minimal TB, aged less than 16 years, randomized in a 1:1 ratio, and followed up for 72 weeks for the primary outcome assessment. If you see the bar graph on the right, you can see the schema of the 2-month difference between the arms, where the participants in the 4-month regime received an intensive treatment of 8 weeks duration, which was the same as the 6-month arm, and a continuation phase treatment of 8 weeks duration versus the standard 16 weeks duration in the 6 months arm. We used new pediatric dispersible FDCs and WHO recommended weight band dosing. Additionally, we also conducted 2 nested PK sub-studies in selected sites. One was among children taking anti-TB drugs as new FDCs, and the other was among HIV-TB co-infected children to evaluate the PK interactions between anti-TB drugs and antiretrovirals. The next slide, please. So SHINE trial enrolled participants from 5 sites, 3 in Africa and 2 in India. In Africa, we enrolled in Kampala, Uganda, Lusaka in Zambia, and Cape Town in South Africa. In India, the enrolling sites were Pune and Chennai. The PK sub-studies were led by teams in Netherlands, South Africa, and Chennai. MRC CTO UK is the main coordinating center for the trial. Next slide, please. The trial population included children below 16 years of age who were weighing more than or equal to 3 kg with no known drug resistance. They had a a clinical decision to treat with a first-line regime, were symptomatic but with non-severe TB, with smear negative respiratory sample. A gene expert positive report was allowed in respiratory samples. Children who were not treated for TB in the previous 2 years, and those who had known HIV status were the other inclusion criteria. We defined non-severe TB as extrathoracic lymph node TB or intrathoracic lymph node TB with minimal or no parenchymal abnormality on chest X-ray, the absence of cavities, and a smear negative respiratory sample. Additionally, we excluded participants who had other forms of TB, severe TB, including miliary, spinal, TB meningitis, osteoarticular TB, abdominal TB, and congenital TB. Next slide, please. The primary efficacy outcome was a composite unfavorable outcome that included TB treatment failure or TB recurrence or death by 72 weeks or on treatment loss to follow-up. The primary safety outcomes were grade 3 to 5, proportion of patients experiencing at least one grade 3 to 5 adverse event at the end of treatment up to 30 days after the last dose. Next slide, please. There were three main analysis populations, the primary of which is the modified intent to treat. This includes all randomized participants, but excludes late screening failures, those who did not reach week 16, and those who were lost to follow-up before week 72, after completing treatment and being clinically well. Next slide, please. We also did the intent to treat analysis, which included all randomized children, and a per protocol analysis, which excluded participants who were non-adherent to the trial medications, in addition to the exclusions in the modified intent to treat. Next slide, please. The trial was powered on key secondary analysis in children educated to have TB at baseline. We assume that number to be 80% of all children. Next slide, please. And based upon previous phase 3 treatment shortening trial in adults, the non-inferiority margin was set at 6%. Next slide, please. So this was the overall trial background with the analysis plans. I now hand over the presentation to Dr. Kinikar to present the main results of the trial. Thank you.
Good afternoon, everybody. Thanks, Priyanka, for the trial overview. Coming to the actual trial, we screened around 1461 children, and for screen failures, we excluded 257 children. The remaining 1204 were randomized with 602 in each arm of 4 months and 6 months. For our primary analysis, the population was 572 in the 4 months and 573 in the 6 months arm. And for per protocol analysis, we had 563 and 558 children respectively. Can I have the next slide, please? Coming to the baseline characteristics across the two arms, there was a good balance in the baseline characteristics. There were relatively young children in both the groups with a median age of around 3.5 years and about 10% HIV positive children in both the arms. As we see, all of the children had some or the other symptom of tuberculosis at the start, and nearly 14% were bacteriologically confirmed cases. Can I have the next slide, please? As far as the adherence to randomized duration and retention, there was a good and balanced adherence to the randomized duration at around 94% in both the arms, and we had around 95% retention at week 72 across both the arms. Next slide, please. Coming to the primary efficacy analysis, as you see it in this particular slide, a risk difference of 0 means no difference in the two arms. The primary endpoint risk difference is on the same line, about 0, with a tight confidence interval. Also, the upper bound is well below the 6% non-inferiority margin, showing that the 4-month regimen is as good as the 6-month. Can I have the next slide, please? As we see here under the three different types of analysis, the results were consistent across the intention to treat analysis as well as the per protocol analysis. Also, if we look at this consistency in the key secondary analysis of those educated to have TB at baseline, the Endpoint Review Committee education of TB at baseline was approximately 80% of the children, as was assumed in the sample size. And this is similar in both the arms. Can I have the next slide, please? There were some unfavorable outcomes, and the reasons for these 34 unfavorable outcomes have been listed here in the table. And these were in the primary modified intent to treat analysis, where we see that both the groups of 4 months and 6 months took into account as death from any cause, loss to follow-up, TB recurrence, any TB treatment extensions, or treatment failure where the drugs were restarted or there was a change of treatment. Can I have the next slide, please? Coming to the primary safety on treatment adverse events, which were taken as grade 3 and above, here we see that overall there was no difference in the adverse events between the two arms. We had a total of 16 adverse reactions which occurred, and among them, 11 of them had raised liver enzymes. Most of these reactions tended to occur in the first 8 weeks and which settled down gradually without any untoward outcomes. Next slide, please. To summarize and conclude from the data which has been presented today, the 4-month treatment was as good as 6 months in children with minimal or non-serious type of TB. There were, although few unfavorable outcomes, but they were equally noted in both the arms. Looking at the published data and our trial findings, we could urge to say that 2/3 of the children with non-serious TB could be potentially treated safely for 4 months. Also, when we talk of shorter treatments and the duration, it means that there is lower cost for both the family as well as the health system. And with this data, we would like to urge the guideline and policy makers that they should consider moving for the 4-month treatment in children, especially those with non-severe type of TB. Can I have the next slide, please? To end with, we would like to acknowledge all the study participants and the families who have contributed to the conducting this study. Also, all the trial teams at the various sites where SHINE study was conducted. And of course, the various committees which were overseeing the entire trial and making sure that the study was implemented in the right manner. Next slide, please. At the forthcoming 2020 TB Union Conference, there are 2 oral presentations which are coming out of the SHINE trial. One of them would be presenting the SHINE trial findings, and the second one is in relation to pediatric TB lymphadenitis. As well as we have 3 poster presentations, one of them looking at the color vision testing. The second one is the method of baseline education. And the third one is the caregiver's beliefs in anti-TB treatment. So to end the presentation, next slide please. I would like to thank the entire SHINE trial team. And this is a photograph of the last investigators meeting in Zambia, where everybody was present in person, though today we are meeting through a virtual platform. However, the intention is the same, that we would like to disseminate and discuss the SHINE study trial findings with you all, and hope that the policymakers take due cognizance of the findings which have come out of this randomized clinical trial. Thank you very much.
Yeah, thank you both for a very clear presentation of very important work and really well presented and on time. There will be some questions in relation to this presentation at the end. So just to be aware, there's the issues around, as we're moving towards consideration, this will be considered for guidelines in terms of, in the past, smear positive cases would not be considered non-severe, but now with expert positive and some bacteriologically confirmed, that's one issue to consider. Also the programmatic issues of having shorter regimens, and clearly the issues of how much more important adherence might be for 4 months and 6 months. These are some of the questions that will become up for discussion. So please start thinking around your responses to those. I'd like now to introduce to give us an update on TB preventive therapy trials in children. Annika, as you all know, is the director of the Desmond Tutu Centre in Cape Town and with Stellenbosch University. Over to you, Annika.
Thank you, Steve. Can you hear me? Steve, can you hear me?
Yes, Annika, loud and clear.
Okay, great.
Yeah, I can hear you. I muted.
Sure. Thanks so much to the organizers for inviting me, and I'm going to stick to time, and these slides will all be available. I must say, to speak after the SHINE results is challenging because it's so exciting, but I think the focus and the emphasis should very much also remain on prevention. Prevention is going to be better than cure, but I'm absolutely thrilled to be able to be part of the team that presented SHINE to you. And we're going to give a brief overview of what's happening in the clinical trial space for TB preventive therapy trials, specifically focusing on kids. So as you saw from some preventive therapy regimens, and you'll see that there are some gaps, both for data, notably for 3-HP in young kids and in HIV positive kids, but also, so we don't use rifapentine in kids below the age of 2, but also gaps in terms of formulation limitations. And so we actually do not have pediatric formulations for rifapentine. So we actually have gaps of 3-HP for both ages as well as for formulations. But then we also have gaps for 1-HP, which you can see is now a conditional recommendation, but only from age 13 years and up. So this is important to note, that we actually have gaps for existing regimens recommended, and we can't bring them to all kids who need them in the field. And you also saw the very encouraging data on the increased uptake of preventive therapy. However, this is actually only initiation. This is not completion.
Negative and positive are included.
I think there's someone else speaking. So it's really important to note that shorter preventive therapy regimens will have been shown. Shorter preventive therapy regimens have been shown to not only lead to higher completion rates, but also to be safer and better tolerated. So the priority gaps that are currently being addressed in trials are in 3 areas, and I'm going to also mention one cross-cutting area. The 3 areas are for 3-HP, for 1-HP, we're going to look at DRTB, and then the cross-cutting area, I'm just going to give a brief update on some of the formulation challenges, notably rifapentine. So what's the first gap? It's 3-HP, and especially in those kids below the age of 2 years. And as we know, those are the kids that have the highest risk of getting TB and bad forms of TB, like TB meningitis, which Cara nicely presented on. So this TBTC study 35 is looking at 3-HP in kids across the age spectrum to 0 to 12, and specifically aims to address these data gaps, but also in HIV positive kids. And this trial is actually finally making nice progress, and these are the 4 age cohorts, and we actually hope to open up these younger 2 age cohorts and specifically test these child-friendly formulations in kids below the age of 2 years. It does include HIV positive kids, but the trial is actually not powered for looking at the effect of drug-drug interactions with ARVs, notably dolutegravir and efavirenz. The timeline for the study, it's currently on track. Interim analysis has shown great results. We're on target for PK as well as for safety targets. And we had actually already hoped to reopen the trial to be able to study these young children with all the age groups opening in parallel now, but there's been a delay with a challenge in nitrosamine impurities in rifapentine. It's also an issue with rifampicin, and this is something which has been widely discussed and we hope can be moved forward rapidly. So we hope that during 2021 we'll be able to generate data on 3HP, including in HIV-positive kids down to ages 0, which is really important and then can help inform hopefully updated policy guidelines. The next question is 3HP with the appropriate ARVs, and notably having robust data on dolutegravir. And this question will be addressed in Dolphin Kids. It's part of the Large Impact for TB Unit 800 project. It's led by Nicole Slarizan Austin. And this study will specifically look at focusing on drug-drug interactions and getting really robust data on dolutegravir and 3HP in kids. Again, this trial, looking at the timeline, is also being hindered by this challenge of rifapentine impurity. And this trial will likely go forward using the adult formulation that is actually crushed and seeing how low we can go. And we can actually be sensible and pragmatic about using the existing adult formulation. The second priority in terms of knowledge gaps is 1HP. And clearly 1HP is more doses, it's 28 doses over 28 days, but it's only in 1 month. So it's actually going to be potentially even easier to give than 3HP, which is rifapentine and INH once a week for 12 weeks. So it relies on taking medication once a week over 12 weeks. So 1HP is clearly very attractive from an initiation, uptake, and completion perspective. And so the next study that is going to address this is specifically going to look at the data gaps which have been posed by this amazing large efficacy trial, which was completed in adults and adolescents and HIV positives. And this 1HP or brief TB trial showed that 1HP was actually not inferior to 9 months of daily isoniazid. It was better tolerated, was safer, and adherence was obviously excellent. There are some additional gaps, potentially in adults and in adolescents, and then also potentially in children. There's going to be an operational pragmatic trial looking at the tolerability, the effectiveness, and the preferences in the field of 1HP versus 3HP regimens in adults and adolescents. And the question is actually whether one would also need a pediatric study to compare these two regimens, 1HP versus 3HP. So that's an interesting point for discussion. For 1HP, so that is 28 days of rifapentine only, there are clearly gaps in how do we actually dose the rifapentine on a daily basis, because that's not the same as giving rifapentine once a week with isoniazid. This is once daily for 28 days. And these questions will actually be addressed both looking at 1HP in its own, but also with the effect of ARVs and drug-drug interactions in the Impact 2024 study. And the study is currently in planning. Again, the study is also hampered by the same issue, which is the challenge in not having a pediatric formulation available for the trial. And this trial will also be pragmatic and sensible and move ahead by using the existing adult formulation crushed. And we are exploring, and the trial team is exploring, and how we can actually use adult rifapentine formulation in an extemporaneous manner, and whether one could actually make this a bit more palatable in the field. And just using the adult formulation as best one can. So this trial will hopefully open in 2021, also in international sites. Priority 2 is the cross-cutting issues, and that's really focusing on the rifapentine issue, which I have mentioned earlier. And I'm not going to go into detail, but essentially there is a nitrosamine impurity in rifapentine and rifampicin, which has raised potential concerns about safety that are quite theoretical at this stage. It is being addressed by the various stakeholders, but this is actually impacting both formulations being available for the clinical research, for the trials, as well as formulations in the field to people who need them for already existing recommended and licensed drugs and regimens. So this is a real challenge. What we currently have that's licensed for rifapentine that is being proposed to use in these pediatric trials is this rifapentine 150 milligram tablet, which you can see is quite dense. It's not scored. And then there's some various trial formulations that are being used, for example, in study 35, which I presented earlier to you. That's a 3HP trial. But these are just trial formulations. These are not actually commercial products. And Sanofi, which is the main developer of rifapentine, has actually put the development of any pediatric formulations on hold until they actually sort out this impurity issue. So this is a brief summary, and I'm not going through all the detail, but essentially this is the current status. Formulation work is actually on hold for pediatric formulations. The impurity is actually in the active pharmaceutical ingredient, so the thing from which we actually make these the rifamycins, and it's actually in both two sources of the API globally. So it's actually impacting on everyone. But in the meantime, while these impurity issues are hopefully being addressed and also being discussed with WHOPQ and with others, in discussion with these various pharma companies, it has become clear that they would really welcome having a very clear guidance on what a pediatric formulation eventually would need to look like that could actually be prioritized for development there. The PADO TB group, which Farhana has mentioned, recently convened, and it actually looked at several options for rifapentine, and this is some data that was presented to them. And working with the core group, with the rifapentine working group, and many discussions around the simplicity, ease of use, what's going to be the most useful in the field. A consensus was that 150 milligram rifapentine standalone tablet would be quite useful and could be used potentially with multiple regimens, for example, 3 HP or 1 HP, and potentially down the line also for treatment of DSTB. And study 31 results will be announced at the Union, and that's an adult TB treatment shortening trial, including rifapentine. And the benefit of scoring, as you see here, is really for the youngest kiddies, so below the age of below the weight of 7 kilograms, where we can actually see that if we score a tablet, we can actually use the scoring mechanism, that we would actually have a somewhat lower exposure, but still above the target than we were actually used to not having a scored rifapentine tablet. So this is some of the modeling work done by Radha Savik and Kendra Ratka. And the summary from the TB PADO meeting, just high level, is that 150 milligram scored dispersible rifapentine formulation would be useful. And obviously, it needs to have other things too, which would make it durable and useful in the field. And this is actually something that will then inform the manufacturer's prioritization for which formulation to move forward when they eventually do move forward, rather than being told to make 3 different things and then nothing moves forward. So finally, concluding, and I'm still on time, the final priority is DRTB. Here we don't have results yet to present, but I can tell you of 3 trials that are underway. And as you know, the current WHO updated guidelines make a conditional recommendation and talk about potential use of preventive therapy in selected high-risk contacts. And this is really because there's really no clear evidence from trials. There really have not been any randomized controlled trials conducted on DRTB prevention. There are now 3 trials globally underway. The one is TB CHAMP, which uses levofloxacin to look at preventing TB in child household contact 0 to 4 years of age. There's a large sample size of over 1,000 kiddies. There are, at the moment, 600 children enrolled, almost 600. It's implemented in South Africa. The second trial is VQuin. It's fully enrolled. This is a trial implemented in Vietnam and in collaboration with the Vietnamese NTP. And this trial primarily focuses on adults and adolescents, but has a modest number of children enrolled. You can see a large number of household contacts. This is fully enrolled, and the last follow-up will be completed in March 2022. So we expect results in 2022. And then the last trial, which is Phoenix. And this is actually, all these trials are looking at the household as a unit of intervention. And Phoenix targets adults that are HIV positive or have a positive test of TB infection, HIV positive individuals, or children below the age of 5 years. And the regimen there is delaminate versus standard dose isoniazid with a large sample size, and about 10% of that trial is enrolled. And this is happening in multiple sites internationally. So the CHAMP trial, just as a reminder, these are the main questions. It's being implemented in South Africa. This trial has really been challenged in the sense that COVID-19 hit. Before that, we actually had to pause due to insufficient funding. We have now secured full funding from Unit Aid, but COVID really wreaked havoc, and the trial was paused to accrual between March and July 2020, and is now actually back on track and reopened. But it's important to note that many of these trials will rely on adequate TB case detection, and obviously that has been impacted negatively by the COVID-19 pandemic. Lastly, the Phoenix trial, which I mentioned, which uses a different regimen compared to VQuin and TB CHAMP, is underway. And these are the primary and the secondary objectives. So it's really looking at efficacy and safety. It's a once daily delaminate dosing regimen. So it's not twice daily as we give for DRTB. There's multiple other secondary objectives. And this trial is now about 10% enrolled, but also paused due to COVID, and it's actually reopened in October. And this is where Phoenix is being implemented, and you can see very wide global representation and currently has 25 international sites. So thank you very much for all the collaborators and colleagues and for the use of your brains and of your slides. Thanks.
Thanks, Annika, for giving us that update, and congratulations to you and your team for contributing so much in this area as well. Really fantastic work. So I'd like to ask now ask James Seddon to give his annual selection of interesting peer-reviewed articles. So over to you, James.
Hi, can you hear me okay? And can you see my screen?
Yeah, both.
Okay, great. Thanks very much for inviting me to talk today at the meeting and give a review on papers that have been published in the last 12 months. So this is some search terms that I've put in on childhood tuberculosis, and you can see that there have been 36,000 papers that have ever been published on childhood TB. And if we look, we can see that there's been a sort of continued increase in papers published on this topic, which is really exciting to see. If we restrict the terms to the subsequent year, running from a couple of days ago to the year before, we find 1,126 papers, which I dutifully waded through. And I'm afraid, as always, this presentation comes with biases. I did look through all these papers and I found 90 that I thought looked really interesting. This year, there's been so much attention on COVID and TB. I've not really addressed that because a lot of them are opinion pieces rather than science. And there was a huge amount on BCG, partly BCG and COVID, but just BCG generally. Given this is a virtual meeting, the whole meeting's a bit shorter. I've only been given 15 minutes rather than 20, 25 or 30 as I have in previous years. So I've included fewer papers. Initially, I only started with 15 papers, but I just kept having to go, oh, I've got to include this one. I've got to include this one. Now, please, if I've not included your paper, don't hate me. And if I do a terrible job of summarizing your life's work in 1 minute, also, please don't hate me. Okay, I'm going to get straight into it. So the first paper was published in PLOS One. 3,000 children and adolescents in Uganda undertook a tuberculin skin test survey in 2015-16, divided into children 5 to 11 years and adolescents 12 to 19 years. And really the prevalence of TB infection in the children was 8.5% and adolescents 16.7%. And 9% of all these children had a household exposure. And the risk of having TB infection was higher in those who had a household exposure in children, but less so in adolescents. And when they looked at the population attributable fraction of having TB infection due to household exposure, it was only 8% in children and 4% in adolescents, which really shows that children and adolescents are getting a lot of their exposure to TB from outside the household. Moving on to this paper that was published in the Lancet, which Leo is going to talk about later today, so I'm not going to go into it too much, but effectively this was a systematic review and individual patient meta-analysis of TB risk following close exposure to TB, and this found 46 studies from 34 countries and included over 130,000 children. There were 130 prevalent TB cases and 1,000 incident cases. And I'm not going to talk about the results because Leo, I'm sure, will do that just now. Moving on, this top paper was published in BMC Medicine. It's a simulated study of TB epidemiology in India, Indonesia, China, the Philippines, and Pakistan, the 5 highest burden TB countries, using an agent-based model combining household structure and social mixing, and age-specific infectiousness and infection rates. They really looked at how the different epidemics propagated. And what they found, which I thought was fascinating, is in India, Indonesia, the Philippines, and Pakistan, the 15 to 19-year-olds, even though they only represented 5% of the incidents, represented 20% of the transmission. And in these 4 countries, childhood TB represented 1/5 of incident cases. So children and adolescents really being very important in both the incidence and propagation in high burden settings. The bottom study was conducted in Peru, published in BMC Medicine. Study in 2005 to 2007 looked at clustering of cases of childhood TB in children under 5 years of age. And they used complex mathematical models to try and see where clustering was more extreme than might be expected by chance. And they compared this to another study which used molecular methods to look at transmission hotspots, and they found a very good overlap. So basically you can use clustering of child cases under 5 to show where lots of transmission is happening, and this could be useful for case finding. Moving on to diagnostics, the first paper was a really massive study published in PLOS One, 10 cities in India, conducted from 2014 to 18, where expert was used up front to evaluate children with possible TB, provided free at point of care. A staggering 94,000 children were evaluated with a median age of 8 years, and 6,000 or 7% were diagnosed with TB on expert, with same day time to results, and 93% started on treatment. So it's just showing that upfront expert testing is feasible even in a high burden setting. And the bottom study on this page was published in the American Journal of Respiratory and Critical Care Medicine, a study that was done in 2012 to 17, where 195 children with TB symptoms were investigated extensively. Ultimately, 40 had confirmed TB and 100 had unconfirmed TB, and they undertook induced sputum and nasopharyngeal aspirate samples. Now, these samples, as well as being analysed in real time, were frozen, and now what they've done for this study is they've thawed them out and conducted expert ultra on them. This is really trying to evaluate how good ultra, the new test, is on these samples. And really the sensitivity of one induced sputum and one nasopharyngeal aspirate was about 80% compared to culture on the same sample. So really not bad, and improved on the earlier versions of expert. So next study, done in the Gambia, 140, published in eBiomedicine, 143 children, of which 44 had confirmed TB and 60 had clinically diagnosed TB, and the rest had other diseases. And these children was divided into a training set of 260 children and a test set of 171. And the group evaluated 27 cytokines and found that a 3-protein signature of IL-1RA, IL-7, and IP-10 were a strong signature in the training set. When that was put to the test set, it was found to have 71% sensitivity and 75% specificity, and that worked across age ranges and sexes. So a good signature for discriminating children with disease from children with other diseases. And then the study below, a small study, really a case report or a case series published in Pediatric Infectious Disease Journal in London, 10 children between 2010 and 2020, investigated with EBUS. So that's endobronchial ultrasound transbronchial needle aspiration. I have to say that very carefully. And what this really is a bronchoscope with an ultrasound at the tip. So you put the bronchoscope into the airways and then perform an ultrasound on the edge of the wall of the airways to find out where the lymph nodes are, and then put a needle through the bronchoscope to take a sample for histology and microbiology. And they did these samples under conscious sedation and had rapid on-site histological evaluation, which gave a diagnosis in almost all of them at the point of the investigation. And there have been a couple of previous case reports on this, but I think this really just shows that, especially in high-resource settings, this could be a tool that we can use, especially as the scopes get smaller and smaller, which they are. Moving on to therapeutics. The first study was done in Kenya and published in Clinical Infectious Diseases, a clinical trial between 2016 and 2018. 300 children who were HIV exposed and uninfected at 6 weeks were randomized to isoniazid or not isoniazid. They hadn't had any TB exposure, and that most of them had been BCG vaccinated. And the endpoint was whether they developed TB infection, measured by a positive IGRA or TST. And what they found is that the rate of TB infection in the non-INH arm was 13.5% and 7.6% in the isoniazid arm. So it's a bit unclear what's happening here, because there's obviously an interplay between TB infection and BCG and isoniazid. But it's interesting that that there has been a substantial reduction in rates of TST positivity, mainly in the children who received isoniazid, and it was safe and well tolerated. The second study was performed in Mongolia, published in the New England Journal of Medicine, a really colossal study where 8,851 school-aged children from 6 to 13 years of age with a negative IGRA test were randomized to vitamin D or placebo and followed up conscientiously for 3 years. By the end of the trial, and the primary endpoint was whether the vitamin D could prevent the acquisition of TB infection. And by the end of the trial, 3.6% of children in the vitamin D arm and 3.3% in the placebo arm had a positive IGRA, so really no difference. And 21 children had developed disease in the vitamin D arm and 23 in the placebo arm. Again, really no difference. So although this is a sort of negative trial to some extent, I think there's been talk of vitamin D for so long that this trial has really put to bed that vitamin D does not prevent infection or disease if given to children. The next study was published in the Lancet Global Health, and it was a modelling exercise to compare 2 different strategies. The first is to treat all household contacts of infectious TB cases with preventive therapy, or test them first with TST or IGRA, and then only treat people who were positive. And the model used data from clinical trials of 4 months of rifampicin and 6 months of isoniazid and 3 months of rifapentin and isoniazid, to look at both efficacy and adverse events. And they looked at this through different ages and background TST prevalences. And what I think that's relevant for the pediatric population is that for under 18s, giving preventive therapy to all households or all contacts results in very few adverse events and has good efficacy, and it's probably not necessary to perform any test of infection. And in this age group, 4R is found probably to be the best. For adults, though, as the age increases, the rate of adverse events goes up, and there's increasing merit in doing a test of infection before providing preventive therapy. Second study on this page is a case report of one child, a 7-year-old girl with TB meningitis in Australia, who was given first-line treatment with an isoniazid, rifampicin, pyrazinamide, and moxifloxacin, but who then at 8 weeks developed optochiasmatic arachniditis. This is a severe complication of TBM that's life-threatening and vision-threatening. And the child was given 3 doses of infliximab and steroids and really developed very rapid and complete recovery. And I think this is very interesting because it really tells us that we need to think more cleverly about the host-directed therapies we use in TBM, and perhaps infliximab is a drug that needs further investigation. Thinking about HIV and TB. First study published in the Antimicrobials, Agents and Chemotherapy was done at 5 sites in South Africa from 2013 to 2015. And this is on the background that lopinavir, ritonavir is normally given at a ratio of 4:1. And what has been shown in the last few years is that to create adequate doses of the PI in the presence of rifampicin, you need to increase that ratio to 1:1 lopinavir, ritonavir. But it's really unclear what that does to the other antiretrovirals. So this study was to evaluate what happens if you increase that ratio of ritonavir to lopinavir on abacavir levels in children. So 87 children under 15 kilos were enrolled and sampled at 3 time points during the intensive phase of TB therapy, the continuation phase, and then after TB treatment. And although the abacavir availability fell by 36% when on this double super boosted regimen, it still remained within the target range for adults. The second study was published in AIDS, and was done in children from 2 to 12 years with TB and HIV at 4 sites in South Africa. And we know that rifampicin impacts on raltegravir dosing, but we don't really know what the dose adjustment should be to compensate for this. So raltegravir was given at 12 milligrams per kilogram twice a day to these children, which is double the normal dose, in combination with 2 NRTIs, and then intense PK was done 5 to 7 days later. And what we found, or what the study found, is that the dose was safe and well tolerated, and the target PK achieved in all children was fine, and 92% of children had suppressed viral loads down the line. Moving on to vaccines. The first study was published in BMJ Global Health, and it analysed the DHS survey data from 13 countries in sub-Saharan Africa and looked at children under 5 years. And in these children, they've looked at BCG vaccine status, the most recent malarial rapid antigen test, which is done as part of these surveys, and any history of fever in the last 2 weeks as a surrogate for symptomatic malaria. And a huge number of children, 34,000 children were sort of identified through these surveys, of which 12,000 had a positive malaria rapid test. BCG vaccination in these studies was found to be associated with lower malarial prevalence, with an adjusted odds ratio of 0.94. And this protection increased with the age of the child and retained for both symptomatic and asymptomatic children. So it's only a modest reduction in malaria prevalence. But what's going on here, and how is BCG affecting malaria? And BCG seems to be doing everything. The next study was published in Nature, fascinating study, which I'm sure many of you have seen, where 52 rhesus macaques were randomized to receive either subcutaneous, aerosolized or IV delivery of BCG. The team then did transcriptomics and flow cytometry analyses of various body compartments. And then 6 months later, the macaques were challenged with a virulent MTB given through the airways. After they were given this challenge, they had repeated FDG PET scans to evaluate the extent of disease. And what was fascinating is the IV BCG had substantially more extensive immune response in CD4 and CD8 T cells in the blood, spleen, BAL, and thoracic lymph nodes. And 9 out of 10 of the macaques given the IV BCG were protected with no signs of infection or disease on the PET scans. So maybe this is a way to move forward to think about BCG vaccination strategies. The top study here, also looking at BCG, published in the Lancet Global Health, was a model of 152 high-burden countries, and they looked at 12 different scenarios to give BCG at birth, 6 weeks, 6 months, and then delayed to 9 to 12 months. And they varied these with different efficacies and coverage. And then they evaluated what the impact that would be on death by TB before the age of 15. And really 100% BCG vaccine coverage at birth reduced deaths by 16.5%, and later administration increased deaths even if delivered with the DTP vaccine at 6 weeks. So really continuing neonatal vaccine and aiming for 100% coverage is what we should be looking at. The lower one was a study published in Journal of Infectious Diseases, done in Guinea-Bissau between 2003 and 2009. And within the context of an early measles vaccine trial, child and maternal BCG vaccine scar status was measured. So at just over 2,000 children, and 83% of the children had a BCG scar, and 44% of the mothers had a scar. And in the child, having the scar was associated with a 41% reduction in mortality. But what was interesting about the study is that if the mother also had a scar, the child had a scar and the mother had a scar, that reduction in mortality went down up to 66%. Whereas if the mother didn't have a scar, but the child did, the protection was only 8%. So again, what is happening that a mother with a scar and a child scar has additional protection, and maybe there is some maternal priming going on with this. And then a few studies looking from a fundamental science perspective. The top study was published in Frontiers in Immunology, performed in Manchester in the United Kingdom, and alveolar macrophages were taken from 20 healthy infants and 20 healthy adults who had bronchoscopy for other unrelated issues. And then those macrophages were taken and incubated in the lab with live virulent MTB. And the team then did RNA sequencing, flow cytometry, and cytokine evaluation. And what they found was that the infant macrophages were less able to restrict the growth of MTB compared to the adults. And transcriptomics showed a lower expression of genes involved in mycobacterial protection. So really interesting. We know that young children are more susceptible from going to infection disease, but we don't really understand why, and this might shed some light on it. Second study on this page was published in BMC Pediatrics, undertaken in China from 2016 to 2017. 18 children with pulmonary TB and 18 children healthy controls, stool samples taken at recruitment, and then for the ones with TB at follow-up, and then they've done DNA sequencing of the stool samples. And children with TB at baseline had less diversity than controls, and with upregulation of pro-inflammatory bacteria and some opportunistic pathogens. They also had less protective bacteria. And then on treatment, admittedly a small number were able to be followed up, but the treatment led to reduced diversity of the gut microbiome. And this relationship between the microbiome and TB and the microbiome is obviously hugely important, and we need to understand it better. And in the last couple of studies, the first published in eBiomedicine, undertaken in the Gambia in 2015, 29 pairs of children from 5 to 15 who, in the pair, there was one child who's highly exposed to TB with a negative test infection, and the other highly exposed to TB, but with a positive test infection. And then samples in these children were tested, and both with luminescence in vitro functional assays and other interferon-based cytokine work. And what we found is the uninfected children had higher levels of luminescence and produced less BCG-specific interferon. So that's a really interesting finding to find out why are some children developing infection and why are some protected. And the final study was a fascinating review published in the Lancet Infectious Diseases of novel imaging in childhood TB, and looking at both clinical care and research. And the article discussed the strengths and limitations of chest X-ray, and then brought in cross-sectional imaging, CT and MRI, as well as PET. And then also moved on to using imaging that had mycobacterial specific markers, so ingesting markers that were taken up by mycobacteria then could be identified using imaging. And finally, you could inject labeled antibiotics and then scan the children as well. So I think in the future we'll have a paradigm where we will be able to, we don't need to sort of look closely in children. We will be able to do this remotely by injecting mycobacterial specific markers and antibiotic specific markers, and then scanning children to see what's going on. So in conclusion, wow, the number of publications increasing is going year on year higher, and there were multiple publications I really would have liked to include in this presentation. This year we did have a lot on BCG and lots of papers on COVID and TB, which I've not covered. There remains good geographical variation. I think in the past, most TB research was done in a few centres, and that's getting better and better. And so on that, I'd like to finish.
Yeah, thanks very much, James. Thanks for highlighting so efficiently the fact that there are increasing numbers from different settings and high quality, looking at all different aspects. Finish on the fact that there might be better imaging than chest X-ray from you. I think that's great. I would like to, in the next 15 to 20 minutes, just open for discussion. If we could just go back again, because of the format we're working in, it might be best if we just see if there's any additional questions for Karen around TB meningitis. Jackie Oliwa from Kenya highlighted the challenges of making a diagnosis of TB meningitis when you can't do lumbar punctures. So that's one issue. And I think the other one that James just alluded to as well, in the case of CNS TB, people are, at least here in Australia, are moving to replace ethambutol with moxifloxacin. They're using higher doses of rifampicin, perhaps more aggressive anti-inflammatories. So I just wonder whether you yourself, Karen, or James could give us a bit of an update on perhaps novel approaches to TBM. That would be a start. Thanks to you, Karen.
Thank you, Steve. I think James might be better suited to answer that. James, are you willing?
I'm happy
to take that
say a few
one.
things. I mean, I think there is quite a lot of science that will come through in the next couple of years. I mean, Kelly Dooley's TBM Kids is looking at new therapeutics with higher doses of rifampicin and levofloxacin. I think the results of those will be exciting. The SURE trial is also using higher dosages, up to 30 milligrams per kilogram rifampicin, and bringing levofloxacin into that regimen, and is also using aspirin to see if that's there. I think there's increasing interest in different host therapies. and people are trying all kinds of things, and also thinking about whether we can do slightly more biomarker targeted host directed therapies to give different therapies based on what pattern of disease you're seeing. So I suspect in a couple of years for TBM, we will see different therapeutics with higher dosages and slightly different drugs that penetrate the CSF. And I suspect we will have more targeted and more considered host-directed therapy.
Yeah, and Karen, to Jackie's reference, you know, I mean, early diagnosis and treatment, whatever you treat with, is critical, and you don't have, you know, good laboratory support. Any comments on that?
Yes, Steve, I think that's an important consideration. And I think one of the reasons why we don't have good data for pediatric TBM, because of the capacity in many high burden settings that's so different. So I think it's important that we utilize and see what we have, and really looking at different strategies to have to adequately sort of try and identify children using multiple strategies, not only sampling, but also other diagnoses. And I would love to, I've already texted Jackie that we take up those conversations. And I'd really encourage everybody else who's willing to talk about identification and surveillance of TBM in other countries to please contact me. I'd really love to hear. It's really surveillance. I know that some of the trials, even the treatment trials, also have been struggling with enrollment. And it's difficult to estimate the number of children that you will enroll at a site. And I think that's why it's so important to have better data on the burden of disease.
Thanks very much, Karen. Could I just ask the speakers for the SHINE trial, and it may not be the actual speakers or others to do with the SHINE trial, there are reflections on, I think, two questions that sort of came through. One is what might be the programmatic challenges of having different regimens for different types of TB in children. And I think, you know, I think we're aware that smear positive was considered to require a 6-month regimen, but now we have expert, etc., the reflections on that. And I think also, if you're going to shorten the regimen, is it more critical that full adherence is achieved? Is there any efforts to follow up and see how much relapse there might be in the 4-month versus the 6-month? Those sorts of issues. So I'd like to hear from folk in the SHINE trial around that, if we could.
Hi, Steve. It's Angela here, recruit statistician, MRCCTU.
Yeah, sure, Angela. Great. Yep.
Great. I saw a couple of questions in the chat. So one of them, yes, about the relapse. So there were 10 recurrences as indicated by the endpoint review committee, and we can't distinguish whether they were relapses or new infections, but there were only 10 of them. And the other question about the subgroup analysis of the children who were culture positive, and that was only 14% overall. So given the small number, there isn't anything sensible to say about the event rates in those two groups. I think it was less than 5 across both arms. And but we did pre-specify a number of subgroup analyses. All of those analyses showed a consistency of the finding that there was no difference between the 4-month and 6-month arms. Another point to say that might not have been clear from the presentation is that there were only 3% of events overall, except we of course were only counting events after week 16, at the point at which the arms were different, and actually there were 4% of events actually occurred prior to week 16. Okay, that's all I was going to say. And there was another question about adherence, and adherence was very high. You'll have seen that was presented. And so in terms of how much you would need to safely treat the 4 months, I think from these data, adherence was so high, we wouldn't be able to put a lower threshold on that. Thank you.
Angela, if you wouldn't mind, just reminding folk, there's a question from Raj Dayal just come in to remind us of the diagnostic criteria and the endpoint used in the SHINE trial, just quickly.
So smear negative, non-severe TB, determined by chest X-ray, and the endpoint was a composite endpoint, TB recurrence, death, on treatment, loss to follow-up, and there's something else which there's another one to check, but it was on the slide. Majority were deaths, actually, TB recurrence.
There was, this is Dr. Aarti here. There's one question on the programmatic challenges.
Please, if you could take that on, Dr. Aarti, great.
Yeah. So I would like to say that under a programmatic condition, if there are clear-cut guidelines as to what exactly amounts to non-serious tuberculosis in children, it will be very easy to implement because it's already there in the system, the entire thing. And if a flow chart like how we have at present in our national guidelines or also the WHO, so implementation won't be a problem. Also regarding the dispensing of the drugs, one would be 4 months and the other would be 6 months. So that would also not be an issue. What is required only is monitoring of these children over the next 1 year, which is not there actually in the program. Because if there is a recurrence or a relapse, that needs to be picked up much earlier. So given a chance, it won't be much difficult. In fact, people would like to have these children going for 4 months if they are non-serious rather than exposing them for 6 months. It's just that we need a flow chart which explains it very clearly what is the meaning of non-serious TB. Thank you.
Yeah, that's really good. So thank you for that. That's a really important point. And I guess it's important to remember that these children are not starting off on different regimens. They're on the same regimens. It's just that you can stop one earlier than the other depending on those criteria, and that has to be well defined. But adherence will be important. But it's not like they're on different drugs or different dosages or different regimens as such. And I think that's an important point. There's a question regarding the rifapentine impurity and the following precautionary measures by Sanofi and how this might affect countries. Annika, are you able to take that on?
Yes, thanks, Steve. So there are two manufacturers for rifapentine products currently that are kind of available at some scale. That's both Sanofi and McLeod's. That is a generic company based in India. As I currently understand it, the Sanofi impurity issue is being worked on and addressed by Sanofi for their active pharmaceutical ingredient or API, which they're manufacturing themselves. And the idea is actually that the US FDA has given them a period in which to resolve this, during which time the existing adult rifapentine formulation will still be allowed to be used and marketed because of the pressing need for these drugs in the field. And that would be the same for McLeod's. There's also a discussion with WHO pre-qualification about what level of impurity would be acceptable or not. So it's important, I think, to note that the FDA in the US and the EMEA in Europe and WHO pre does seem to be at this stage on more or less the same page. So that pertains to the adult formulation, which is the licensed product. And then there's also a fixed dose combination made by McLeod's, which is also WHO pre-qualified. But however, the pediatric formulations, which I mentioned really quickly, are still kind of trial products. So these are actually not commercial products yet. So they're not licensed, they're not approved. And so their development is put on hold until this impurity issue can be resolved. And the expectation in terms of the regulatory authorities for the level of impurity is actually that it's extremely low. And so whether it's actually going to be possible for these drug companies to make the rifapentine with this low level of impurity remains to be seen. So I think information will be coming out soon, hopefully. But I think what is encouraging, Steve, is both routine care and perhaps for some clinical research that the regulatory authorities have stated the importance of continuing using the rifapentine given the risk-benefit assessment of its use. The potential carcinogenic risk is really calculated from people taking rifapentine basically for their lifetime, and then a hypothetical risk associated with that. Whereas actually, if we use it for TB, whether it's for treatment or prevention, it's actually very short duration treatment. So I think there's a lot more that needs to be discussed there, but I think it's reassuring to all that it can be allowed to be used, and it does seem to have been cleared to continue being used for both routine care as well as for research under carefully specified conditions. And hopefully we have more updates in the next couple of months.
Thanks, Annika. Dr. Arti, sorry.
Yes. Yeah, can I take the question on the smears?
Yes, please. I was going to ask.
Yeah. So under the national program, every sample from a child which we send, if it is sputum or it is gastric aspirate, it does undergo a smear testing. And immediately it is put into the gene expert as well, because that facility is available. What happens is the yield which we get from the smears in children below 5 years of age is very low. But if we have an older child who is around 6, 8 or 10 years, we have got positive smears of 1+ or sometimes 2+. So the smears are being done under the program. So people have a tendency to go towards the gene expert or the ultra expert testing, which gives a much faster result. Thank you.
Thank you. Di, would you like to briefly comment on the programmatic issues, and then we go back to the impurities?
Yeah, thank you very much, Steve. Hello, everyone. It's Di Gibb here. Yeah, just briefly, I mean, I think that is, there are two key things following these results from the SHINE trial, which are, as presented, very reassuring that the 4 months is non-inferior. The first is obviously from the programmatic point of view, having a stratified approach does add an element of complexity, although I think Dr. Arti eloquently said, well, it's the same regimen, etc. It is just shortening it, the extension phase. We are doing some further economic analysis and also looking from a programmatic point of view about what it would require, because the other key aspect is identifying the children who have minimal TB. And we have got an enormous amount of baseline data on these children, and we'll do some more complex analyses to try and look at the best way in the field, if you like, including where things are not so available to identify these children. And then I think that will help to push forward to implementation. I don't know if anyone else wants to add anything.
I think Sabine had some comment to make on this.
Yes, sorry. While we were speaking about this, you know, we were wondering around. Currently, actually, country programs, very few of them are actually able to take specimens of children, let alone do AFPs. Obviously, currently we're having expert as recommended as initial diagnostic test. But in the absence of, I mean, if you look at the data of in children, especially young children, the majority of children do not even get any of the tests, and we are hoping that obviously stool testing will make it a little bit easier to at least attempt a bacteriological confirmation of TB disease in children. But so to me, the question is, in the real life setting, at primary healthcare level, where children access care, how is it going to be possible for healthcare workers to identify those children who could benefit from a shorter regimen in terms of the definition of minimal TB being based on AFP negative results? Thank you.
Just to come back on that, I obviously didn't explain it very well, but the idea is to include all the data we have, which includes the clinical and contact information, for example, in order to try and, but has everything else as well, and use particular analyses to try and answer that very question, Sabine. So I think you're absolutely right. And what we have in this data set is all the lab results, is all, you know, the X-ray and lab, but as well as that, the clinical and contact, etc. information, so that one could therefore apply how one would do this at a grassroots level. Does that make sense? I mean, I think it's a really important aspect.
Yeah, thanks very much, Di, and thanks, Sabine. Sabine, back to you, if I could, or Anamika. Lindsay may want to ask herself, but I think it's an important question. Is WHO planning to put out anything around a statement around the impurity issue for rifampicin and some formulations of rifampicin in terms of being able to judge risks and etc.?
I think this is something that is being looked at by the PQ department, but we can find out the details and their plans of addressing this issue.
And to add to that, this is Anamika. We had a meeting over the last 2 days with UNITAID grantees, partners, and project countries. And UNITAID also mentioned that there will soon be a communication on this issue from their side. And they are working with our colleagues who are the focal points for TB preventive treatments.
Dennis, did you have anything to add?
No, that's it. Thank you very much. Hi, this is Dennis Falso. I'm a colleague of Anamika. So that's it. And I think we expect more from PQ on this shortly. Okay,
and so I'd like to finish, if I could. We're getting through the time, but if I could ask Blessy would like to make some comments in regarding the lack of progress around TPT and the challenges of the COVID situation. So Blessy, over to you to make the last comments, questions, please.
Thank you very much, Steve. I wasn't expecting to ask. I just put in the chat box. But anyway, no, I mean, yes, everybody said it was an excellent report. But actually, it is very sobering, isn't it? When we look at the lack of progress, it just goes to show that we have to take this seriously. And if we look at the 20% progress for TPT and 0.9% progress, I mean, these are really worrying things. Anyway, the point I'm making is that COVID has affected everybody. So there isn't a separate area that we need to look at for children. Because if the hospitals are closed, health centers are closed, children are affected. Two things I think we need to look at is really look at the COVID report, community report that was launched globally recently. We can circulate it for you. Look at what people on the ground are saying. And number two, mental health issues of children, especially children with TB. Huge numbers. Children are isolated. I think we need to give serious attention to this. And then the third thing is whatever decisions are made, whatever policies come out, on the ground, if people are not convinced, the uptake is going to be very limited. And communities are doing everything working at the ground level. And I think that needs to be, kind of given value and recognized. For TPT, we did a huge push. I mean, starting with TAG, the Global Coalition of TB Activists, we worked with Southeast Asia Regional Office of WHO in bringing partners together. We developed a community brochure with simple questions that can be answered. And we really, so I think in a working group on childhood TB, I think it would be important to sort of recognize these contributions as well, so that, there is, we also feel recognized and encouraged to keep pushing forward. Yeah, that's basically what I wanted to say. And thank you for answering the question about rifapentin. It is a huge concern for us, and we are getting a lot of questions from our own colleagues, and we want it, cleared so that we can give the right answers. But thank you very much for this.
Thank you, Blessia. Much appreciated. I think that's a great time now to end this session, and I'd just like for you to all join me in thanking all the speakers who did a really excellent job of clear, succinct presentations, a lot of information, very welcoming. So thanks to all. Back to you, Annemieke and Sabine.
Great, thank you very much. We also understand that Ben was held up in hospital, and so he couldn't join. And we hope that he can join. It's not going to be too late to join the second session. In the meantime, we will take a break. We will keep the line open, but obviously stop the recording and restart it for session 2. So we will be restarting at 2:30 European time. So that is in 1 hour and about 45 minutes. And we hope to see many of you there again. And of course, if it gets too late, being on the Australian side, then rest assured that both sessions will be made available. Thank you.
Everybody's already unmuted.
See you later.
Thank you.
Thank you very much, Steve.
Thanks, Annemieke.
So I would I'll take this opportunity to welcome you to the next session. We have 3 presentations, each lasting 15 minutes, and the session is focusing on developments in diagnosis of TB in children and adolescents. So the first presentation is a sharing of a country experience in implementation of the simple one-step stool method using experts. And this will be presented by Edine Tirmesma from KNCV, Netherlands. Over to you.
Thank you, Maureen. I will start sharing my slides. Can you see my slides?
Not yet.
Not yet. It's coming.
They're coming.
Good.
Yeah, we can see it.
Great. Okay, so thank you, Maureen, for introducing me. So the simple one-step stool method, as you know, was developed by KNCV and first presented at the Union Conference of 2018. I will have to stop my camera, I see, because the CPU usage is too high of my computer. Let me see how I do that. Okay. Let me see. And then stop video. Okay, sorry about this. Let me return to the slides. I hope you can now see the screen again. Okay, so it was first presented in this working group last year in Hyderabad. So that was very great that we got the opportunity there to present some of our work. And I'm also very happy that again we get the opportunity to give you some updates. As for those who have not yet heard previous presentations, this test is really as simple as sputum testing with expert. And it is thus feasible to perform the test at any gene expert laboratory. And there's no additional materials needed, maybe except for a wooden rod. And only a short training is required for expert staff to be able to conduct the processing method. So in very simple pics, it looks like a little bit of stool is added to the sample reagent that comes with every cartridge of Cephide. There is some mixing done, sedimentation, and 2 ml of the supernatant is then added to the cartridge and then tested with Gene Expert. So as an update, I would like to show you what studies we are currently doing. Of course, we had really hoped to show you a lot of results already, but due to COVID, a lot of our studies got much delayed in enrolling patients. So unfortunately, we are not as far as we hoped last year. But we will still give you hopefully some exciting updates. So we're currently conducting an accuracy study in 2 countries, Ethiopia and Indonesia, where we compare the expert stool test using our simple one-step stool processing method with expert on culture and culture on the NGA or sputum sample. We're also involved in the studies conducted by TB Speed and Find, comparing our processing methods with other processing methods in different countries in the world. We're looking a little bit more into the robustness of the stool method in 2 countries, Ethiopia and Zambia at the moment, just to see, for example, what are the best storage conditions? How long can a sample be stored at what temperature to still give valid tests, etc. Also, we are doing some pilots, really applying this SOS stool processing method in a normal routine. And we're doing this in Vietnam, and you will hear about this in a few minutes. And then we are also involved in a demonstration study in the peripheral sites in Ethiopia. You will also hear about this in this presentation, so I won't go into details now. And furthermore, we are also working on modeling the impact and the cost effectiveness of this simple one-step stool processing method at the primary healthcare level with the University of Sheffield. And we hope to be involved in some more projects that are coming up soon. With this, I would like to hand over to Ndala Mangasha Goshu, who will present the implementation of our projects in Ethiopia. Ndala, over to you.
Okay, thank you very much, Edina. Hi all, my name is Ndala Mangasha. Then I'm happy to have this chance to present the SOS Stool project in Ethiopia. Then the map that you see is the Ethiopia map, the accuracy and robustness study, and the SOS method robustness study. Both are conducted in the capital of Ethiopia, Addis Ababa, and the demonstration small-scale implementation at the zonal level in 2 zones, Bench, Shako, and Kafa zone. Next, Edina. Next slide. Okay, the accuracy study. This study involved 26 health facilities expected to enroll 1,250 children. As per the following SOP, then after the clinical assessment for eligibility of the enrollment, child with a presumptive TB, according to as per the national guideline and less than or equal to 10 years age, not severely ill will be included in the study, and requested to provide 2 NG sample and 1 stool. Among these, 1 NG sample and a stool sample were performed by using expert MTB REF Ultra assay at the site level, while the 1 NG sample is transported to the National Reference Laboratory for TB culture. Next, Edina.
I'm trying to advance in Dale. For some reason, it's difficult. Maybe it takes some time.
It's difficult to go to the first slide.
It doesn't advance for some reason. Ah, now it does.
Okay. With this accuracy study, we have provided training, hands-on training for 2 lab technologists and 2 clinicians, as well as for the health facility head to have the orientation. So from each 26 health facility, this means, and after 7 months of enrollment, we did a midterm review and got feeding retraining of the staff. Next.
Yeah, I'm really sorry that it's so slow. It doesn't advance. I don't know.
May I share from my computer? Or?
Maybe that's better indeed. I will stop sharing then.
Adele, do you want to keep going as you upload your slides?
Could you see my slide?
Yes, please go ahead.
Okay. I was here, then we provided the training, hands-on training for health facility staffs from the 26 health facilities. Then on this slide, as there is a preliminary result for the accuracy study, and as of September 2020, a total of 430 children were enrolled. For this, for stool expert TB REF assay, 429. NG expert MTB REF Ultra 430, NG for liquid culture 389, and for LG solid culture 359 were performed. For the culture, there is around more than 40 samples were pending, still waiting for the result, and among the total positives from the NG expert MTB REF assay, one patient didn't provide the stool, and the one additional provided after 2 weeks and resulted negative in stool. The positivity rate, as you can see, for the stool 4.7%, for the NG 6.3, and the liquid culture 5.1, and NG in solid culture 3.6. Error rate from the expert stool 5.4, NG expert 4.9, and the contamination rate in liquid culture 10%, and in the liquid culture 8.4%. So this is a preliminary result for the accuracy study. Further fine-tuning for the SOS stool method, which is, we called it the PORTEC experiment. Then accuracy study, MTB positive child on the NG or stool are requested to provide 2 additional stool specimens on the consecutive days, and from both specimens, expert experiment 1 for sampling strategy will be performed. Then after this, experiment 2 for storage condition. And experiment 3A, optimum incubation of the specimen and the sedimentation time. Also there is experiment 3B, contact time with sample reagent with the maximum time in room temperature and refrigerator temperature. In addition to this, there is also an experiment called 3C, amount of the stool added to the sample reagent. Will be fine-tuned in this experiment. So among a total of around 26 experiments will be performed in the lab for fine-tuning the SOS method. The other is a demonstration, the zonal level demonstration, a zonal level implementation experience. 2 zones were selected in the southern part of Ethiopia. Zonal coordinators were assigned 20 health facilities with high TB case load selected. 12 lab technologists were trained for SOS method, and orientation was provided for 95 clinicians. Digital specimen referral and result notification tool adopted from Indonesia, which is called Citrus application, which can work as a web-based and mobile-based application. Baseline TB notification data were collected. Improvements in childhood TB case notification rates will be monitored. As a take-home message, difficult to achieve the projected sample size due to COVID-19. Logistical issues not to be underestimated, like gene expert machine need upgrading for ultra cartridge utilization as based on the version of the software. Continued retraining need due to staff rotation, especially for when they are assigned in the COVID service. Then the stool well received by the NTP and peripheral laboratory as alternative specimen for expert testing. Children guardians favor stool much above NJ as a specimen for diagnosis of TB. SOS stool method for expert seems robust and well accepted. It's a game changer in the diagnosis of childhood TB at peripheral level. Thank you very much. Edina, you can continue. I'm done from my side.
Yes, thank you. I'm trying to share my slides again. And I will try to speed up a little bit. Okay, I hope you can see my slides.
Yes.
Good. So for Vietnam, this is a pilot implementation project in 10 sites, including tertiary care facilities and district health centers. And they're indicated by the stars on this map. It's a routine implementation, really in the routine. So stool expert testing is really done alongside the current diagnostic algorithm. We include children and persons living with HIV and intend to include a total number of 1,000 patients in this project. What will be compared, that is the expert test result on the NGA or sputum sample as per the diagnostic algorithm and clinical diagnosis, and that will be compared with expert on stool. We will also collect some other data and extract the GXX files from the expert machines. So the issue, of course, then when COVID came up, we couldn't go to the countries to conduct the training. So Petra and my colleague Andri also provided distance training using video and audio and real-time presentations, giving exercises to the participants which they had to do in their own labs, tape on video or make photographs of it. And those videos were then discussed between the trainers and the trainees, after which a competency assessment was done and a post-test was given. And this was followed by a kickoff meeting in which it was really checked if all the labs were really ready to start with the implementation. The lessons that we learned from this training was that it is feasible, but of course there's less interaction, so you cannot really check if the training is well internalized. It was actually quite time consuming for the trainers, and it's very much dependent on the translation and the quality of the videos made by the trainees. Sorry. The preliminary results of this implementation projects are given here. You can see that almost an equal number of children and persons living with HIV were included. You can also see that only about half of the children, even less of the people living with HIV were tested with the expert on stool. So there's likely some selection. You can also see that from the very high positivity rates on experts, both on the NGA and on the stool in children. What is also striking is that the error results were very, that was a high proportion. I have to add that this mainly occurred in only one laboratory code, which continuously produces the same error code. We are currently investigating what is going wrong there. And actually, in all the other laboratories, after the repeat, really most samples give a successful result. And what we also see is that this rate goes down when staff gets more experienced. So the 21% is really mainly due to an issue in one of the laboratories, which has nothing to do with the staff conducting the method, I have to say. So in general, including all other projects, we can say that the stool method can really be feasibly implemented at the peripheral and district level if there is initial close monitoring and troubleshooting. A training, including a training of trainers, can be provided remotely. The head-to-head comparison studies, for as far as we have seen some very preliminary results, suggest that there's no difference between the three stool processing methods. And as I already said, currently we are estimating the cost and the impact of implementation of our method at the peripheral level. The SOS stool method can be used for children and for adults, we see. And it can probably also be combined with other buffers. And that's a study we're doing in Zambia. We're also still awaiting results of the robustness study. Due to COVID, the enrollment of children has greatly delayed. And there's more work coming up. So as next steps, we see that we, of course, want to complete all the studies and other work on the SOS stool method. We also want to finalize an online SOS stool toolbox in which we provide guidance on the training, monitoring, and supervision. We are planning to make a general implementation plan and provide guidance on the interpretation of the diagnostic test results. And in collaboration with the WHO, Peter's working on preparation of a quick guideline of stool processing methods, including ours. We're also intending to create a community of practice of all those working with the SOS stool method. Thank you for your attention. Sorry, this took much longer than expected due to some issues. And I'll hand back to the chair.
Thank you, Edine and Indal, for taking us through the experience in using the SOS method in Ethiopia and Vietnam. We'll quickly move on to the next session that will focus on emerging experiences with diagnostic approaches in children with HIV, severe pneumonia, and malnutrition, presented by Chishala Chabala from Zambia. Over to you, Chishala.
Okay, good afternoon and thanks. So I'll share with you our experience of using nasopharyngeal aspirates and stool samples for microbiological confirmation diagnosis of TB in children. I'm presenting this on behalf of the TB Speed Consortium, and my name is Tishara Chavala, like introduced. I'm based at a University Teaching Hospital in Lusaka, Zambia. So the TB Speed project, the main goal of the TB Speed project really is to contribute to the reduction in childhood mortality from tuberculosis. And the project aims to do this by evaluating feasible and cost-effective strategies using innovative diagnostics tools and decentralized approaches for improving diagnosis in high burden settings. So the project will be implemented in 7 countries. So these are the countries that are listed here. And then one in Asia, which is Cambodia. And the main approach is to evaluate microbiological diagnostic approaches for children. And this is mainly being done through collecting nasopharyngeal aspirates and stool samples, because these have been shown to be highly feasible and have a relatively good performance with expert and are now recommended by the WHO. And then these are then tested using the GeneXpert platform, using the G4 in the lab, and also a battery operated G1H, which could be placed at in the ward and at primary healthcare settings. So this component of the TB Speed project is targeting highly vulnerable children that are considered highly vulnerable. As although these are children who are HIV infected, children with severe acute malnutrition, and children presented with severe pneumonia, because these have been shown to be at a high risk of TB disease. They're also the high risk of death and at high risk of being underdiagnosed. And so within this group, within the project, we have 3 studies that are assessing each of these groups. So we have the TB Speed Pneumonia, which is evaluating these diagnostic methods in children below 5 years who've been hospitalized with WHO-defined severe pneumonia. And then we have the TB Speed SAM, which is evaluating children with severe acute malnutrition who are aged below the age of 5. The TB Speed HIV, which is looking at children up to the age of 15 with presumptive TB. And what I'm sharing with you this afternoon or morning, depending on wherever you are, is the preliminary results focusing on the feasibility of nasopharyngeal aspiration and stool sample collection, and using these samples to test on an expert ultra platform for the diagnosis of these groups of children. So the first study, which is the pneumonia study, really aims to evaluate the impact on all-cause mortality at 12 weeks of adding systematic early detection of TB with expert ultra, which is performed on 1 nasopharyngeal aspiration and 1 stool sample, and then followed by TB treatment if positive. And this is then compared to the standard of care, which is you give antibiotics and other adjuvant treatment, and when the clinician suspect that it could be tuberculosis, then they order tuberculosis test. So the design of this study is a cluster randomized trial step-wage design, and it's being conducted in 15 tertiary level hospitals in 6 high TB incidence countries, and these are Ivory Coast, Cameroon, Mozambique, Uganda, Zambia, and Cambodia. And the study aims to recruit 3,780 children aged 2 years to 59 months, and they should be newly hospitalized for severe pneumonia as defined by the WHO. And then the control arm is the WHO standard of care. Then an intervention arm will perform, as long as the child meets a diagnosis of severe pneumonia, will perform expert ultra upon admission, and the nasopharyngeal aspirate and the stool sample. And those that are found positive are treated. All the hospitals that are participating in this study will start with the control arm, and then at 5 weekly intervals, one hospital is randomized to implement the intervention until all the hospitals are able to come into the intervention arm. So these are the baseline results of the children that we've recruited so far. We've recruited 1,940, and they're young, 11 months on average, and 5% are HIV positive and 8 concomitant malaria, and about 20% have severe acute malnutrition. And when we look at the nasopharyngeal aspiration, so of all these children who were admitted to the intervention, we managed to collect, to attempt in 97%, and 96% more than it was successfully done. And we have a valid test on these children in up to 95% of them. So we only had 2 invalid results, and then we have some errors or no test results. And then when we look at the stool collection in this group of 6 children, so out of the 619 children, 100 children did not have a stool collected, and of the 83% had a stool collected, almost 77% had valid results obtained from the assessment. We had about 7 invalid results and errors from the ones who had a test performed. Then I move on to the next study, which is the HIV study. So the primary objective of this study is to evaluate the proportion of children who would be missed when the Panther treatment decision algorithm is used. So the Panther treatment algorithm is an algorithm that was developed by the Panther group, and this publication is listed down here. And this study was performed in Cameroon and Burkina Faso, Vietnam, and Cambodia. And they developed a predictor score which could predict TB diagnosis if you used certain laboratory and clinical parameters about the patient. So the aim of this study is to evaluate this Panther score in a different setting with different levels of HIV infection. So 7 hospitals are participating in this study in 4 countries, in Cote d'Ivoire, Uganda, Mozambique, and Zambia. And these countries did not participate in the original Panther study. The aim is to recruit 530 children aged 1 month to 14 years. And with this, we have a presumptive TB based on the Panther inclusion criteria. So this is the Panther score. So a child comes with a presumptive diagnosis based on the presence of cough or fever and the symptoms that would be considered as defining presumptive TB. And then the expert ultra is performed, and then the child is given a score based on the result, history of contact, and other clinical parameters. So each clinical parameter and laboratory parameter and radiological parameters and ultrasound that are performed on each and every child have a score that is apportioned. And when a child has accrued a score of more than 100, that according to the Panther score is highly predictive of TB, and they are therefore initiated on tuberculosis treatment. So basically, this study is validating this scope on this group of children using these parameters. So we've enrolled 65 children so far. The median age is 5 years. 9% had a previous TB diagnosis. We've had quite a number who also had concomitant malnutrition, 40%. Some mild anemia, 58% were on ART at the time of inclusion. And a good number of them had a cough as a main symptom and other clinical parameters suggestive of presumptive TB. So when we look at how the NPA performance goes in these 65 children, so out of the 65 children enrolled, 63 had an NPA attempted and 59 had a successful one, and all of them had a valid test performed, representing 90% of the children that have been enrolled so far. And then when we look at S2, out of the 65 children, so 5 children did not have S2 collected. And then when you look at the ones who had the expert test done, so 55 of these children had a valid test, only 2 had an invalid result, representing 84% of the children enrolled. The last component of this study is a TB speed sound, which is looking at children with severe acute malnutrition. So the primary objective for this component of the TB speed is to develop a diagnostic prediction score for diagnosis of TB in children with severe acute malnutrition. As we know that there's always a tremendous challenges in diagnosing TB in this group of children. So it's a prospective diagnostic cohort study. It's been done in 3 hospitals in Zambia and in Uganda. The aim is to recruit 720 children with severe acute malnutrition, aged between 2 months and 59 months, and they are hospitalized with severe acute malnutrition. And then these children are then assessed with having a nasopharyngeal aspirate, 2 sample, radiology, ultrasound, quantiferon TB good, and some blood tests. But the decision to start the treatment is based on the usual standard of practice within the hospital. So those that have bacteriological conformation are started, and those on whom the clinicians consider that meet the diagnosis of a clinical diagnosis of severe malnutrition are managed accordingly. And then we will then retrospectively classify these children as confirmed, unconfirmed, and unlikely TB, and then we'll develop an algorithm based on the clinical information and other diagnostic tests that the children will be subjected to. So in this group of children, we have enrolled 137 so far. On average, they are aged around 14 months. They have anemia, and most of them had severe wasting, and then 14% are HIV infected. And when we look at how NPA collection has performed, so we performed out of the 137, we performed 135 NPAs, and 2 were unsuccessful, and we had 129, which is 94%, had a valid test result from the NPA. And when we assess this 2 collection, out of these 137, we did not collect 2 on 8, and in those that we successfully collected 2s, we managed to get results in 84% of them. So in conclusion, this preliminary result shows that it's highly feasible to collect nasopharyngeal aspirate and for children with the highly vulnerable children for TB, and that we had almost more than 90% of the children had a valid ultrasound result from the nasopharyngeal aspirate. We also demonstrate that there's a high feasibility to use tools in HIV infected children and children who were hospitalized for malnutrition. We noted that there was slightly more challenging in children with pneumonia, chiefly because these are quite sick children. And then these methods are also being assessed at a lower level outside the hospital setting, at district and primary health care facility in the component of the TB speed, which is called the TB speed decentralization. And then we'll conduct a qualitative assessment on the feasibility and acceptability of these methods, which will be starting very soon. We'll interview parents and healthcare providers just to get more insight on these processes in terms of acceptability and how easy they are to perform. The final results of the TB split pneumonia will be expected in 2021, and the HIV component in 2022, and the malnutrition in Q3 of 2021. We know that microbiological confirmation doesn't always get all the TB cases that you want in children. So we are also looking at other clinical pathways for diagnosis, and some of this will be presented in this symposium on the 23rd of October. And please take time to listen to these presentations if you can. So I think that's the end of my presentation. Thank you very much.
Thank you very much, Chishala, for taking us through the experience from the multi-country TB speed study. For purposes of time, we'll quickly move into the next presentation, which is which will be given by Laura Olbich from University of Munich on T-cell marker-based assays for the diagnosis of tuberculosis in children and adults. Over to you, Laura.
Okay, can you guys hear me? Hello, Maureen, can you guys hear me?
We can hear you.
Okay, perfect, thanks. So good afternoon, good morning, good night, wherever you are. Thank you very much for inviting me to give this talk. My name is Laura Olbrich. I'm a clinician scientist at the Tropical Institute in Munich.
Laura, it's incredibly low. I can barely hear you.
Okay, is this better now?
Much better.
Much better.
Okay, thank you. So I'm going to be talking about T-cell marker-based assays for the diagnosis of childhood TB. I believe in this forum, I don't really need to stress why we do need new diagnostics for children. But I would like to spend a couple of minutes on talking about immunoassays. And the slide I will be presenting is actually adapted from Nicole Ritz, and I think she's actually in the audience. So one of the tests that we frequently use for the diagnosis of tuberculosis is the tuberculin skin test, where we inject PPD intracutaneously and measure the induration in the skin 2 to 3 days after. There are some blood-based tests, mainly the interferon gamma release assays, whereby whole blood is collected and incubated overnight and stimulated with TB-specific antigens. And subsequently, the interferon gamma production is then measured. The problem with these two tests generally is that they cannot really differentiate between different stages of TB, meaning between LTBI and active TB. So the test that I will be talking about is the T-cell activation marker for TB, TAM-TB. The first step of the TAM-TB is basically like an IGRA, whereby we collect whole blood and stimulate it overnight with TB-specific antigens. And then in a second step, we look at the interferon gamma producing cells, at the then TB-specific cells, and we look at the expression markers on the surface of these cells, particularly CD27 as a maturation marker and CD38 as an activation marker. And using this approach, we are theoretically able to differentiate between different statuses of disease, between LTBI and active TB, but also no TB. So this approach as a diagnostic approach has been first described by the TB Child study, which was a study in pediatric TB suspects in Tanzania. And here the authors used CD27 as a diagnostic marker for TB. In their cohort, they could show a sensitivity of this approach of 83% and a specificity of 97%. Another study in adults looked at CD38 as a potential marker to differentiate between different stages of disease. And they could show that CD38 reliably differentiates between active TB and latent TB. The potential of this approach to actually detect culture negative TB cases, therefore giving us additional confirmations, is, is shown by this Venn diagram from the TB Child study. If you look at the blue circle in the Venn diagram, we can see that there are 8 cases that were TAM-TB positive, but didn't have any microbiological confirmation. The authors worked up the clinical properties of these patients, and they could show that out of these 8, 5 children are actually very likely to have had TB. Therefore, there is a potential of this approach to give us additional confirmation in children. The first study that actually used this approach as a prospective, in form of a prospective evaluation, was the Refugee Screen AIDA TB study. This was a prospective diagnostic study that we conducted here in Munich, and we included patients with the suspicion to have active TB. We enrolled 338 patients and also included 47 minors in this study. Importantly, this assay was conducted in real time as opposed to the previously shown data, which were all conducted on PBMCs. So our study team was able to develop a protocol using this as a whole blood assay and mainly using CD38 as a differentiator between active and latent TB. The antigens that were used here were AZ6, CFP10, and PPD. If we look at the performance markers here, we can see that in this cohort, we achieved a sensitivity of almost 81% and a specificity of 98%. Just please bear in mind that this is a mixed cohort of children and adults, and just to add, the children in this study were mostly older children, mostly adolescents. We're currently locking the database, so these are preliminary results. The data cleaning is still ongoing, and hopefully we will be able to present the final analysis soon. Based on the refuse screen study, an industry partner, Beckman Coulter, developed the TAM-TB approach into a standardized kit. I will just briefly go through the whole workup. So 1.5 to 2 mils of whole blood are received in the lab, which are then subsequently pipetted into tubes. Of note, all of the tubes that are used within this kit have all of the necessary reagents already frozen down in the tube. So the pipetting steps are really limited. So once the blood is aliquoted into the respective tubes, they are incubated for 16 to 20 hours overnight. And on the next day, there are a couple of pipetting steps and centrifugation steps. But basically, the whole workup of the second day takes around 1.5 to 2 hours per sample. The acquisition then subsequently is done using a flow cytometer, and you will have immediately a result after that. So the whole workaround time of this assay takes maximum a day. The first study to prospectively evaluate this kit in a pediatric cohort was a pilot study performed by Beckman Coulter and our colleagues from the Christian Medical College in Vellore, India. They prospectively evaluated the TAM-TB compared to a microbiological reference standard, which consisted of culture and/or expert. And within a year, they recruited 90 children and performed this assay in this cohort. The diagnostic classifications was following the investigator's opinion here, and their cohort had around a third of patients with microbiologically confirmed TB and a large group of unlikely TB cases. As mentioned earlier, this is the first time that this previously described kit was actually applied, and mainly CD38 again was used for the differentiation between the different stages of disease. The antigens here in this kit, though, are AZ6 and CFP10 and no PPD. For the performance indicators, we can see here that in this cohort, the sensitivity was 80% and the specificity was 84%. I would just like to raise your awareness to the fact that, as I mentioned, the diagnostic classification here was based on the investigator's opinion. And if we apply a more stringent classification, like the NIH consensus statement, where we expect to see follow-up data, we are actually able to increase the specificity to 94% in this cohort. Another pediatric study which is prospectively evaluating the TAM-TB is the Rapid TB study. This is a diagnostic validation study that is currently ongoing, which aims to evaluate a range of new tests with a range of testing approaches and different specimen types. And this includes also the TAM-TB. We will enroll a total of 1,000 symptomatic children in 5 countries, and we aim for a confirmation rate of 20 to 25% to be able to reliably evaluate the test performances. As mentioned, this trial is ongoing. We started enrollment in January of last year, and we are likely completing our target by mid of next year. Our clinical study centers are depicted in dark green here on the map, and they are in Tanzania, Mozambique, Malawi, South Africa, and India. Furthermore, our consortium has a number of academic partners, other stakeholders like FIND or the national TB programs, and industry partners. If we look at the TAM-TB performance so far, we can say that in our analysis data set, we have 571 children with entered clinical data in our database. The median age is 4.6 years, and around 20% of our patients are HIV positive. Right now we have TAM-TB results available in Munich for 171 patients, and our diagnostic classifications follow the NIH consensus guidelines in microbiologically confirmed TB, which, as I mentioned before, is the case for 26% right now in our cohort, unconfirmed TB, and unlikely TB. For us, the unlikely TB category is really very important. So this diagnostic classification is actually based on the investigator's opinion and the fact that no treatment was initiated, and also the availability of additional data like follow-up data and symptoms development and so on. In addition to that, we will have an endpoint review committee that, which is a panel of independent experts that will look at all of the clinical cases and all of the clinical information and will help us with making sure that our diagnostic classification is accurate. Again, the TAM-TB assay used here is the standardized kit using whole blood, mainly looking at CD38, and the antigens used here are EZ6 and CFP10. As I mentioned, this is an ongoing trial, so therefore data collection is ongoing, also data entry and data cleaning, so please be aware of that. And also, due to the fact that we don't have all of our data completed yet, the subset that was used for the analysis that I'm going to present to you now is differing in totals as compared to this slide. So this is the overview of the TAM-TB performance indicators. If you look in the first row, you will see in bold the overall performance. And in this cohort, we have a sensitivity of 56% and a specificity of close to 92%. Of note, and I would like to raise your attention here to the middle column, is the fact that if we take out all of those cases that were slightly confirmed by a single trace result, we increase our sensitivity by 20% to 75%. In addition, and surprising to us, this test particularly performed well in the very young in our cohort, having the best sensitivity with close to 67% and the specificity of 100%. And again, the sensitivity is drastically increased when we take out those children out of this analysis, which were only confirmed with one single trace result. Obviously, one of the limitations here is the small sample size that we have for the analysis right now, but we're very confident to be able to repeat this and present this analysis as soon as we have more data available. To conclude, the TAM-TB does show a promising performance in a variety of different settings and different cohorts for both children and adults. A simplified and very standardized assay kit was developed. And also in our cohort, in Rapid, it does show a promising test performance, particularly in the small infants. While this test does require a certain amount of laboratory infrastructure, like incubation and flow cytometry, we are confident that this can also be applied to settings where one could probably leverage the HIV services that are available. This is not a test that will be performed in primary healthcare settings, but definitely could be applied in settings with a bit more laboratory infrastructure. As I mentioned, this is an ongoing evaluation in our cohort, and as I mentioned, we are waiting for the endpoint review committee to be finalized. But there are other studies as well, for example, ERASE-TB, which are looking into the use of TAM-TB in different scenarios. ERASE-TB aims to find diagnostic tests for incipient TB in household contexts and will initiate recruitment in the beginning of next year. If you would like to know more about our study and the test evaluation that we have done so far, which are mainly the SPK from FIND and also Fujilam, Norbert Heinrich is going to present in the previously mentioned symposium next week, Friday, on our study and also on the findings. This is an effort of a lot of people, too many to name here. Thank you for your attention, and back to Maureen, I think.
Okay, thank you, Laura, for that presentation. Just to summarize, we've gone through the various methods, specifically non-invasive methods, easier approaches to processing stool, and useful information has really been presented. And we have limited time, so I request to hand over to the next session chairs. We can continue to have the questions coming in the chat as the presenters respond to the questions. So over to Lindsay and Susan. Thank you.
Thanks so much. This is Lindsay. And just checking that we have as well.
Yeah, hi Lindsay, this is Susan as well.
Great, wonderful. So to keep on track, maybe I'll do the first introduction. We are on session 2, systematic review risk of TB after exposure, TB screening in children. Our first presentation, and if when you're not mute, that would be great. Our first presentation is by Leonardo Martinez, a postdoctoral research fellow focusing on the epidemiology of tuberculosis in the Division of Infectious Diseases and Geographic Medicine at Stanford University School of Medicine. His research focuses on furthering our understanding of TB transmission dynamics in high burden settings, deriving and validating meaningful and effective interventions to diagnose and prevent pediatric TB, and advocating for the implementation of effective health policy in low-income communities with a high tuberculosis burden. So Leo, right over to you. Thanks so much.
Thank you. Hopefully you can see that.
Yes, please go ahead. Oh,
okay.
Here you
go. Okay. Sorry, one second. So hi, my name's Leo Martinez. I'm at Stanford University. Thanks so much for the invitation to speak here. And today I'm going to talk about the risk of TB in children after close exposure and recent infection. And really this was, and specifically talk about an individual participant meta-analysis that I was one member of a large consortium that I'm going to show at the end. And so I guess I don't need to tell this group here, but pediatric TB is a global health issue. And, millions of children are exposed every year to TB, estimated 15 million children by some estimates. And TB risk in these exposed children is really high. Some estimates upwards of 50% in children below 1 year of age that have TB infection. But the individual and population level impact of case finding and preventive interventions is not well elucidated. And a lot of our knowledge about TB risk in exposed children and children with recent infection is from the historical literature. And I think in TB specifically, we're a little bit spoiled because the historical literature is so strong. This is one example. This is by Ben Murray and colleagues that reviewed a lot of the historical literature prior to 1940 and to display many of the epidemiological concepts we now think about pediatric TB. And this is roughly what he found on the risk of developing pediatric TB after recent infection. This is adapted from that paper. And you can see that the risk of developing TB is very, very high, especially in those below 1 year of age. And then there's a dip after 1 year of age, and then a slight increase after 10 years of age, which could be due to recent infection, reinfection, or some other cause. And so I think this project was an attempt to try to reevaluate and to relook at this question using some contemporary data and to try to compare against that historical data. And to see if things have changed or if the data says something else or the same thing. And so we tried to answer two questions. And the first is, what is the risk of developing TB given recent TB exposure or infection? And the second was trying to understand individual and population level impacts of preventive therapy in these high-risk children. And so I'm going to talk first about this first question. And so we conducted a large individual participant meta-analysis trying to collect all published individual level data on TB risk in contacts of TB cases. And so to be eligible, a study needed to include contacts of TB cases and needed to follow them for incident TB. This is the flowchart. Definitely don't try to read all that. This is a little bit of the summary. We reviewed around 15,000 articles, and we found 80 study cohorts were eligible. And we had sort of an expansive search because we thought maybe some studies wouldn't specifically focus on children and would try to collect all data from all age groups. And so we could try to extract data from those studies as well. And so 46 of the 80 study groups responded to us and said they wanted to collaborate and participate in this project. And that included around 460,000 contacts of TB cases. And this was a little bit of a different, I think a lot of people in the pediatric field are a little bit frustrated because children are often not included in trials and in studies in general. And I think this study was kind of did the opposite. We were more interested in children. And so we had a lot of adult data that we actually restricted. So we had 137,000 children that we included in this analysis. And just some demographic data here. There were, of the 46 study cohorts included, 29 were prospective. And we had generally fairly good representation from around the world. So 10 studies from Africa, 15 from the Americas, but generally good representation. 22 studies reported on HIV. And also, most of the studies, 70% of the studies here reported on preventive therapy, and 80% tested contacts at baseline for either a quantiferon or a tuberculin skin test. And so this study included 137,000 children. All were followed for incident disease if they were healthy at baseline, but they were evaluated for prevalent disease at baseline and within 3 months of baseline. And so once we collaborated with all these groups and we were able to synthesize all the data into one data set, we started to conduct the analyses. And so we conducted mixed effects logistic regression for disease prevalence, and then mixed effects parametric survival time models for incidence. For the impact of preventive therapy, we conducted a propensity score analysis. So to try to adjust for potentially the higher risk contacts may be preferentially given preventive therapy versus lower risk. And so trying to adjust for that in the analysis to some extent. And so here are some of the results. This is the TB risk, the 2-year cumulative TB risk in children with a positive TST or agar positive test. On the left-hand side, a TST negative or agar negative test in the middle, and then all children on the right. And you can see here that there's one group that is higher than the rest, and that is TST positive or agar positive children under 5. You can see here that their risk of developing disease 2 years after exposure is almost 20%. And then similar to the historical data, there's a dip after 5 years of age. And it goes down to around 8 to 12% and stays fairly consistent until 19 years of age. And so I think a couple points to make is that these children after 5 years of age are still they're lower than the under 5-year age group, but they're still really high. 8 to 12% in 2 years is still really high. And so I think often the children under 5, for good reason, are prioritized and talked about more, but I think these older children are also very high risk. And then TST negative and agar negative children, and all children were logically a little bit lower. Just really quickly, this is in 1-year age bins. You can see here that the confidence intervals are fairly wide, and I think there's a few reasons for this, partly because of study power, but also there's heterogeneity between studies. And so, But I really just wanted to show that in the under 5s, it's fairly consistent within that age band. And then in the 5s to 19, it's fairly consistent as well, with some variability, but fairly consistent between 8 to 12% risk. And I think there are some similarities and some differences between the historical estimates that I showed before and then these newer estimates. You can see that the risk is much higher in the under 1-year-old age group, but it's still very high in these estimates, 25 or 20 to 25% risk in these groups. And also, it's fairly consistent throughout 0 to 5 years of age here in the contemporary in our estimates. When there's a little bit of a bigger dip here in the after 1 year of age, and fairly similar after 10 years old. So I think there's no definitely. I don't think one of these is right or wrong. I think that they have different study designs, different time periods, a lot of differences. And so I just think it's important to just take all the information and synthesize it together and just try to understand it together. So we had a lot of data, and so we thought this was an opportunity to also try to look at preventive therapy a little bit deeper. And we found that preventive therapy was highly effective individual level tool to protect these children. You can see here that among all children, regardless of TST or IGRA status, there was a 64% protection against incident disease, but it was modified by whether they were TST or IGRA positive. So over 90% protection in TST or IGRA positive children. And I mean, there's a interesting, maybe suggestive effect among TST negative, IGRA negative children, but it was not statistically significant, but interesting there as well. And also interesting is that this protection did not differ in high and low burden settings. And so it was fairly robust based on how we stratified it in other ways. And so this clearly demonstrates that preventive therapy is highly effective, maybe one of our most effective tools to protect children. We also wanted to look at what proportion of children are developing disease by follow-up time. And I think this can also elucidate the effectiveness of preventive therapy to some extent. And so this is a proportion of all TB that's detected on the y-axis and then follow-up time on the x-axis. And you can see that a lot of TB is occurring very quickly. So among children below 19 years of age, 83% with a baseline positive TST or IGRA were diagnosed within 90 days, so 8 in 10. And so this is even more accentuated in children below 5 years of age, which is this figure. So 83% of all children below 5 years of age were diagnosed within 90 days, and 96% with a baseline positive TST or IGRA were diagnosed within 90 days. So I think this was a little unexpected, the high numbers for us. I think that it does have some implications for preventive therapy because children are developing disease so quickly after exposure, and there may not be enough time to put a lot of these children on preventive therapy before they develop disease. And so also it's important to consider for preventive therapy implementation. So just some conclusions about these results that I presented. Children are at very high risk of developing disease under 5 and with TB infection, up almost 20%. But I think adolescent and young adults, children should also be prioritized based on these results. And I think 8 to 12% is really high risk. So preventive therapy, I think it's clearly this data shows that it's a highly effective individual level tool, upwards of 90% protection in these children. And I think, but I also think this data suggests that we need to try to find ways to make it more effective as a population-based tool. So whether this means combining it with active case finding and community-based approaches, or getting to the exposure event faster by diagnosing the cases that are exposing these children faster, but some way to try to detect, identify these children before they develop disease is going to be critical for preventive therapy. I think that for me, these results it was great to work with and everything, but I think what was maybe even more encouraging to me with this project was that so many study groups, so many people collaborated together, and were really willing to come together to try to answer these scientific questions. And generally, everyone was so friendly and so collaborative, and I think it's so encouraging to me. So I think I really want to, I'm like presenting this work, but really this was a group effort of a lot of people listed here, which I wish I could name, but I can't. Thanks so much. Happy to take questions.
Thank you so much, Leo. Just a reminder for folks to put their questions in the chat and for the presenters to respond in the chat, just given that we have some time restrictions during this session. Susan, would you like to, and a reminder, if you are presenting and able to use your camera, please do so at the request of participants. Susan, would you like to introduce our next speaker?
Yes, I surely would. Thank you so much. I'm Susan Maloney from the US CDC, and I have the pleasure of introducing the next speaker, Dr. Brian Vonasek. He's a pediatric infectious disease clinical and research fellow at the University of Wisconsin School of Medicine and Public Health, and his main research interest is advancing diagnostics and case finding strategies for infectious diseases in children in resource-limited settings. And I'll hand it over to you, Brian. Thank you.
All right. Thank you, Susan. Can you hear me okay?
Hear you well.
All right. So I'll be presenting on behalf of our author group listed here, led by Karen Steingart and Anna Mondalakis. We conducted this systematic review over the past year, looking at screening tests for active pulmonary tuberculosis in children and adolescents. I'll just say from the beginning, this work was done for a recent GDG guideline development group review of the previous guidelines for screening of tuberculosis, and there'll be an update coming out in the next few months. And we contributed to that the GDG discussion with this systematic review. So some of our findings are under embargo currently, so I'm not able to show all of our findings, but I will give a kind of a taste of what we found.
Hola, ¿cómo estás? Bien. Muchas
Please, everyone,
gracias.
mute your microphones.
Please mute.
Okay. So I think the last presentation kind of discussed this very well, but just briefly, we know that there's a big case detection gap for pediatric tuberculosis. This figure here from the recent roadmap towards ending TB really pointed out for the under 5 age group, which we heard in the last presentation is at such high risk for progression of disease. Programmatically, probably less than 1/3 of these children, when they have tuberculosis, are even reported to have tuberculosis disease. And then this point is further emphasized by work that Peter Dodd and colleagues have done. This is a figure adapted from their publication a few years ago, where they reviewed data from 2015 and made an estimate that globally that year there were almost 240,000 deaths in children attributable to TB. And then on the figure here, you can see the majority of those deaths are thought to be in the under 5 age group. And then the vast majority never received anti-tuberculosis therapy. So this really highlights the need for improved case detection and screening for tuberculosis is could have a big impact on improving this this situation. So the primary objective of our review was to determine the accuracy of screening tests for pulmonary tuberculosis in children and adolescent high-risk groups. So to start, we really put a lot of thought into differentiating screening from diagnosis. This is somewhat of a spectrum that you can see on this figure here, where we have the patient-initiated pathway starting with TB exposure and then going down the line to eventually, ideally, a high-quality diagnosis. And then we defined the difference between screening and diagnosis as where this red line is. So to the right of the red line is the realm of diagnosis, where one is being evaluated specifically for TB to give a diagnosis. But then going upstream, so to speak, or to the left of the red line, there are different points whereby children could potentially be picked up early on with their TB disease and then screened and then diagnosed for early treatment of their disease and ideally decreased morbidity and mortality. So that can happen far upstream after TB exposure in the TB close contacts. It can happen with children living with HIV when they kind of are in care, possibly with symptoms and active TB that in that population can progress rapidly. It can happen in children with pneumonia or children that are malnourished. Oftentimes, primarily these kind of presenting conditions are directly attributable to tuberculosis. So we can screen these high-risk populations and possibly detect tuberculosis early on. And then, of course, the under 5 age group is at risk and can have high yield from screening at any point along the spectrum. So we looked at 3 different index tests. We looked at symptoms and kind of sets of symptoms. We looked at chest radiography with 2 different cutoffs, one being kind of the less specific, any abnormality, and then more specifically looking at abnormality suggestive of TB. And we also looked at expert MTB RIF used as a screening strategy. And then we compared these index tests to 2 different reference standards. The first was a microbiologic reference standard. So this utilized culture or expert MTB RIF or even expert ultra done on respiratory specimens. And then we also had a composite reference standard. The composite reference standard was inclusive of the microbiologic reference standard, but it was mostly based upon clinical diagnosis of pulmonary TB. And then we also added a requirement that the clinical diagnosis have a component of follow-up. So as you can imagine, and as you know, the literature, there's a kind of wide range of pediatric clinical diagnostic criteria that are used, but to kind of verify the diagnosis, we required that studies report a component of follow-up. This figure, borrowed from a publication last year by Paul Drain and colleagues, kind of shows the big difference between the 2 reference standards. So for the CRS, the composite reference standard, it does not necessarily require microbiologic confirmation. So you have this middle column here where you would have a clinical diagnosis, positivity for the CRS, but then negative for the microbiologic reference standard. And then as this group knows very well, this can be a big gap for pediatric tuberculosis, especially in the under 5 age group, where we often have a clinical diagnosis, but then no microbiologic confirmation. And then the reason why we emphasize this is when we come to our accuracy estimates that we produce with the systematic review here, it's really important to look at both of these reference standards in context, because neither of them is perfect by any means, and they both have their unique limitations. So briefly looking at the inclusion criteria for our review, we looked at different study types. The majority of the studies that we included were cohort studies. They have to have disaggregated or exclusive data for those under 20 years. The index tests had to be applied with a screening intent, as I sort of described on the early slide. And then they obviously had to apply or look at the index test against one of the qualifying reference standards to provide data for a 2x2 table. And then we did include some data of extrapulmonary TB. Our main focus was on pulmonary TB. So we set a cutoff of 20%. So the cases in any given study had to be no more than 20% extrapulmonary TB. Otherwise, they were excluded. And then finally, some studies didn't necessarily say whether they were looking at pulmonary or extrapulmonary TB. So given our reference standards were what we felt fairly specific to pulmonary TB, if it wasn't explicitly stated in a study, we gave them the benefit of the doubt and included them if they otherwise fit the reference standards that we were looking at. So this diagram here shows kind of our process for including studies. So at the top right, we started with over 2,000 hits from our database search of abstracts and titles. And then we narrowed those down to 16 studies from our database search that we felt fit our inclusion criteria. And then we reached out to this community on the listserv to see if there's anything that we missed with our database search. We did get a good number of recommended studies for inclusion, and we felt that 9 of those fulfilled our inclusion criteria to give us a total of 25 studies that we included in this review. So the 25 studies are listed here. Just to summarize them briefly, they range in publication date from 2006 up until this year. The majority were conducted mostly in sub-Saharan African countries. 5 were conducted in Asian countries, and then 3 were conducted in European countries. 15 of the studies were conducted at least partially in high TB burden countries. So looking at these studies and kind of considering that we have a few different populations and index tests and reference standards that we're assessing with this review, we have a number of combinations to here are 13 of the kind of PICO questions or analyses that we focused on for this review. As I mentioned, these findings were recently presented to in a guideline development group meeting. For that meeting, we focused on the 4 that are highlighted here. We weren't able to dig into everything for the sake of time with that, but we focused on these 4. And I'll just give a kind of a glimpse of our findings for today. So this first analysis looks at chest radiography with a cutoff of abnormality as the cutoff for positivity. And then this was compared against a composite reference standard looking at TB close contacts as the population. So we found 8 different studies that fit this analysis. You can see the studies listed here with the forest plot. Altogether, these had over 3,500 individuals, and pooling these data together, we found a sensitivity of 87% and a specificity of 89%. I hope you raise your eyebrows at those estimates, those accuracy estimates, as we did. We felt they were kind of higher than expected. And one consideration here is that this is against a composite reference standard. So the composite reference standard is driven a lot by clinical diagnosis, and obviously clinical diagnosis oftentimes is driven by chest radiography findings. So when we have chest radiography as a strong component of the reference standard, and then our index test is chest radiography, we have to kind of consider biases, most specifically inclusion bias here. So there is consideration of that potentially leading to overestimates of the accuracy measures that we show here. Another analysis that we did was looking at the WHO recommended 4-symptom screen for people living with HIV. So this symptom screening strategy was initially recommended back in 2011, 2012 in the intensified case finding guidelines that were put out at that time. The adolescent symptom screen was based upon moderate quality of evidence, and the child symptom screen was based upon low quality of evidence. We found two recent studies that really looked at this 4-symptom screen. With this symptom screen, the recommendation is that the screening is to be done serially, or every time an individual living with HIV presents to care. So we evaluated the data with that in mind, and we evaluated screens rather than individuals. So individuals in these studies could have multiple screens that contributed to the data. And then we had over 200,000 screens that we analyzed, and then pooling the data from these two studies together, we found a sensitivity of 61% and an estimated specificity of 94%. So again, that's what we have for today. We have many other findings to share. There will be ongoing dissemination of those findings, and then hopefully they'll have an influence on the upcoming TB screening guidelines that will be put out. And then we also plan to kind of assess TST and IGRA in a systematic review, looking at those tests for active TB in the next year or so. One big takeaway that we had from doing this systematic review is generally there's kind of a lack of studies out there that really look at this question of what's the best way to screen for TB disease in children. So we had some ideas of things that are important going forward for studies to implement. So number one, as I kind of talked about earlier, it's really important to consider both a composite and microbiologic reference standard when looking at screening strategies. And then number two, we found a lot of studies that would screen a cohort and then use some sort of reference standard, but only on those that screened positive. So those that screened negative in certain studies were never really worked up for TB. And this makes sense programmatically to do this, but then in a research context, it's really helpful to also work up those with negative screens so that accuracy estimates, notably sensitivity and specificity, can be made from those data. And then finally, there's probably a lot of room for improvement looking at sequential or parallel screening strategies, whereby complementary approaches, for example, symptom screening and chest X-ray, are used either sequentially or at the same time to really optimize accuracy of screening for child TB. So that's all we have for today. There's many different organizations and individuals that helped make this review possible. So we're thankful to all of them, and then happy to answer any questions. Thank you.
Thanks so much, Leo and Brian. I wish we had more time for questions. We have asked people to put their questions into the chat, and maybe the speakers could look and answer these, and we can also incorporate them into the report. I want to thank both the presenters for very thorough and really extremely useful systematic reviews, both of the risk of TB after close exposure, looking at the historical and contemporary data, and evaluating differential TB screening approaches. And there's a lot of food for us and lots of questions in the chat. So thanks so much. And in the interest of time, I'm going to hand this over to the next session, which is on the impact of COVID-19 on child and adolescent TB services, to the chairs, Hope 2 and Anthony. Thank you. Over.
Okay. Thank you very much, Lindsay. Okay. Before, thank you again for your participation in this session. And before starting this last session, we'd like to invite Bettina to share again this morning video. So over to you, Bettina.
Kopto and Anthony, I'm going to try and play it again.
Okay.
And hopefully there will be sound this time.
And here.
Yeah, yes, you can try. But let's see what happens. I'm going to put it on now.
Yeah.
Can you hear it?
Yes.
Do we have sound now?
Mm-hmm. The sound is on.
No.
No sound?
It's coming, but no really sound. No, I can't hear. No sound.
No sound?
No,
Yeah.
Sabina, we can't hear it.
We don't know how to get the sound going. Sorry, I don't know how to get the sound going. I thought I tested it during the lunchtime and then it seemed to be working.
This is a story of a family.
Sabine, can you look at the left side of your screen? So there is a sound button. What about that?
Pardon?
There is a sound button on the bottom left corner of your screen. Can you put your cursor and see what the sound status there? Yeah, this is here. Yeah, it's okay.
Sabina, we only hear it very softly. Maybe
Yeah,
you can share a link in the proceedings of the meeting. Maybe that we could do.
Yeah, maybe.
So yeah, we can.
Very sorry about this. Maybe
access individually.
Okay. So let's.
Bettina can maybe upload it somewhere where we can then share it for people to hear. Sorry about that.
Yes. Yeah, this is a good idea. Okay. So we can move forward. Can we start the last session now? Okay. Okay.
Yes, please.
Okay. So I will share the session with Dr. Anthony Enimil. Okay, and during this session we will have presentation on the impact of COVID-19 on child and adolescent TB services. So we will have three presentations, and the first speaker is Dr. Anthony Enimil. Is member of Child and Adolescent TB Working Group, is infection disease specialist and head of a Child Adolescent TB HIV clinic from Kamfo Anoke Teaching Hospital, Ghana. So he will share with us the impact of COVID-19 on child, on adolescent TB services and the experiences from Africa. So over to you, Dr. Enimil.
Thank you very much, Co-Chair. Sabina and Anamika, can I get a slide? My share icon is inactive. So if you could share for me to follow up on that. I'm not able to share from my end. Yeah, thank you very much. So impact of COVID-19 on child and adolescent TB services experiences from Africa. Next slide. So briefly, we'll go through the epidemiology in low and high prevalent incidence or incident settings in Africa. And then I will delve into the Ghana example, and then we'll look at the challenges and way forward. Next. So basically, as you are all aware, South Africa is the lead in Africa, sub-Saharan Africa, in terms of COVID. And that's at the time of doing the presentation or presenting the data, it was 682,000 plus. Next slide. So Ghana is a relatively low incidence COVID country. We have had a total of 46,829 with 46,060 recovery. So you can immediately see the diversity of COVID even within the African context. Very high in South Africa, relatively low in Ghana. Next. So delving now into the Ghana statistics, you can see from the last column that the second quarter of 2020, the national outpatient attendance dropped because of COVID. The same period, second quarter 2019, these are the figures, but second quarter 2020, the number dropped, just reflecting the impact of lockdown or COVID over the period. Next. Again, we started seeing COVID late March. April, we were virtually in our peak, and looking at the trend, there was a drop in total attendance, and that goes across all outpatients nationwide. Next. So this is moving into the TB specifics. The previous one was general outpatient attendance for Ghana over the period, but the same trend are lower, but the same trend follows. Looking at the second quarter of 2019, the total number of TB diagnosed was in essence of 3,500. But the second quarter of 2020, the number dropped a little over 2,500, again signifying the impact of COVID over the period. Next. So again, observing the trend, after April, May, June, July 2020, the numbers significantly dropped in terms of total TB diagnosis in Ghana. Next slide. So already in Ghana, between 2010 and 2019, the trend in childhood TB diagnosis has generally been very low. The blue line is actually the observed, which is about 5% of total. From our model, the expected should be around 15 to 20%, and that is in the purple line, the orange line, and then the uppermost are the total numbers. But over the year, the total TB trend has been going down. That of childhood TB diagnosis has actually generally also not been very encouraging. Next slide. So looking at the global, we did an estimate, a surveillance study in 2013, which actually pointed to the fact that TB was about 25% diagnosed. In other words, 75% were undiagnosed, 4 times more TB than we had been anticipating. And using that model in the context of pediatric TB, we seem to have detection gap of about 90%. So we are, per the national figures or numbers reported to national, we were just diagnosing about 10% of what was expected. So if such was the situation in normal times, surely COVID-19 will further worsen the gap in childhood TB case detection. Next slide. So effects on TB services during the 3 weeks of COVID-19. Generally, Ghana was in lockdown in 2 major centers, the capital and Kumasi, where I'm based, for 3 weeks. And then there was a partial lifting, and then eventually we got the whole thing lifted. But the main challenges within the 3-week lockdown was TB clinic was closed, and the follow-up services were disrupted. Of course, at the initial stages of COVID-19, nobody could predict the trajectory. So closed down was closed down, and there were no clinics attended over the period. Again, medication centers were opened, but communication wasn't effective. So the adolescents and the children with TB were not effectively getting their medications. Transportation to hospital for medications were also not available in the main cities because that was when there was total lockdown and no vehicles were moving at all. So this definitely was an obvious impact which most of the adolescents and children could not have control over because it was a national call coming from the president that nobody should go out and no services aside emergency should be given to the population. Next. So there's a WhatsApp group. We have a WhatsApp group for adolescents and mainly adolescents with HIV and or TB. And I put a few questions to them. So these were direct interactions on the WhatsApp group made up of over 50 adolescents with HIV plus or minus TB with mainly the doctors that take care of them. So we share a lot of facts together. When there are updates, I send it to them and they have direct questions. They put the questions there. The team of doctors who are also committed to their welfare respond. And it's a closed group and we make sure confidentiality. So I put forth the question, they should share with us the challenges that they went through. And some of these inputs came directly from the interactions from the adolescent WhatsApp group. So hospitals were closed but mainly to essential services. So some adolescents were not sure if their care was considered as essential. And for that matter, most of them stayed at home. But most outpatients were actually closed. The next point was medication-centered continuous service, yet emphasis was on staying home, which seemed to be preferred option for most of the adolescents. And this was their response. Well, they were not that if I wanted to come, we would have seen them, but most of them took the general rule that they should stay home. And even when they were out of medication, well, they felt the instruction was to stay home, so some didn't feel the need to come. So transport service resumed post-lockdown, but again, there are challenges with real challenges with getting transportation money to come for services, and for that matter, some actually did not come because they couldn't afford the transport, which was in short service, and for that matter, it was more expensive than when the whole issues were post-lockdown when there were no lockdown at all. Next. So in terms of administrative challenges, in the heat of COVID, again, Ghana didn't have large numbers, but we couldn't predict the trajectory. So we seem to have sent a lot of staff to the emergency setting, depriving the outpatients of support. For that matter, most or all outpatient clinics in our teaching hospital were closed down. Again, there were enablers package which supports nutrition and transport for treatment in TB. But again, these were suspended in the heat of COVID-19. And there were no structured system to track adolescents who needed to refill their medication. And again, on the WhatsApp group, they put in the fact that some would have wished to have come, but they didn't really understand the modalities to come to the clinic and how they can access their medication. Next. So way forward to avert future challenges with other potential lockdowns. The recommendation part came from them. If there could be electronic database for us to be able to have a scheduled visit with them and then have a plan for their drug refill. And also if there's an alert system with specific instructions on how to pick their medication. Again, if the system is functional, we should be able to track those who are getting short of medication, send them messages and give them a specific plan. If there's a close by hospital where they could pick their medication, we can supply it and then they can pick it from there. Arrange for WhatsApp and telephonic consultation with clinicians on well-being of adolescents with chronic infectious disease. We do a bit of this because when they have specific issues, they tend to consult directly to one of the clinicians and we respond appropriately. But again, in the context of COVID, their impression was such services were no longer in existence. So they didn't even make effort to consult us. Next. So in summary, we must keep engaging the adolescents with chronic diseases, including HIV and TB. Lessons from COVID-19 must enable us to develop functional models in consultation with the adolescents with HIV, TB, on how best to establish continuum of care during natural disasters and outbreaks. Next. Yeah, so I had data from National TB Control Program, World Info, and personal communication with adolescent TB clinic from Fanoti Teaching Hospital. Thank you very much.
Thank you, Dr. Enimi. Dear colleague, please feel free to write your question in the chat. I think that we'll hand over the next speaker, Dr. Celia Martinez, who is going to share with us the experience from America. Over to you, Dr. Martinez. Dr. Celia? Sabi? I don't know if... yeah, Dr. Celia, she is there. Yeah, she is here.
She was there earlier. Celia, are you able to unmute? I see you are unmuted, but we can't hear you.
Okay. Dr. Enimi, maybe could you introduce the next speaker, the last one, maybe? And mute your, yeah, you're muted. Yeah.
So our next speaker, let me quickly get, our next speaker is Celia Martinez, who is presenting an impact of COVID-19 on child and adolescent TB services experience from the Americas. He is with the PAHU Child and Adolescent TB Working Group. I hand over to you, Martinez, for your presentation. Thank you.
I'm not sure if Celia's audio is connected properly. I can see the mic is green, but we can't hear you.
Yes, and she has just sent you a message to share a slide on the chat.
We need to share the slides? Okay.
Yeah, but we can't hear you, Celia.
But we can't hear, that's, yeah. No, Celia, we can't hear you. I wonder what we can you maybe look at your audio settings to see if the correct equipment is selected? I can hear something now, or is that Copto? I'm trying to open the presentation, but I'm also having some trouble with that at the moment. Oh, there we go. Okay. So I can share the presentation, but if Celia cannot be heard, then maybe, do you want to disconnect and reconnect, Celia? Maybe otherwise, in the meantime, we can get the previous speakers to answer some of the questions, perhaps, while we're waiting for Celia to connect.
Yes, maybe. Yes. If do you have some question for Dr. Enimi, dear colleagues? And
there was
yeah, raise your hand. Yeah.
Yeah, okay. I responded to a comment that came up earlier already. So I'm monitoring the chat as well.
Okay. Maybe you can share it with all of us, all, and Dr. Enimi.
Yeah, so there was a comment on the use of virtual to support the adolescent care. And again, coming from the perspective of Africa and West Africa, definitely connectivity is high, but the difficulty is to do with the reliability of services. So we have a lot of, WhatsApp is reasonable, one of the means by which we easily get to people. And in our case, it is quite common for us to get responses and feedback from the adolescent care. But beyond that, the challenge is getting consistency in data supply and the ability, the cost of data is relatively high. At least I can speak for Ghana as compared to probably some other African countries and Western countries. And the adolescents are not empowered to be able to get enough data to be able to correspond to us as much as we want. That notwithstanding, we are doing our best to keep engaging them with a minimal cost as much as possible, but it's all work in progress because during the COVID, it was the very first time in a very long time that some of us had seen such a thing. And as much as possible, lessons learned will be applied for future outbreaks or future epidemics, for sure. Thank you.
Another question for Dr. Enimi. In fact, I have one question for you, Dr. Enimi. What about direct observed treatment for TB person in Ghana during COVID pandemic?
Yeah, so generally those services were also disrupted, as in when there was the initial compulsory lockdown in the big cities, services were disrupted, especially with the medication. Direct observed therapy in children is actually not done as in the daily routine visit to health clinic. We tend to depend on the caregivers who would they give the medications at home because of trust that we think they will be able to monitor the children. So it's not typically a health worker who supervises the child or the adolescent. It is the caregiver, most especially if the parents are alive. They are the ones that we use and trust them. But they are taught how to mark anytime they give the medication. It's not strictly by a health worker, but by a family member whom we teach how to give the medication, watch out for side effects, and then come for review when they are short of medications. So the issue here is if they did not have medication during the lockdown, then the challenge would be defaulting because they thought the lockdown was so strict that they couldn't even go out or come for medication. But otherwise, the parents are the ones who monitor the treatment.
Okay, great. And you have another question from Andrew?
Yeah, I'm trying to read the question and respond.
Yeah. Andrew asked you, what about BCG stock as well as first and second line drug TB medication? Do you have this?
Yes, we did not have challenges with BCG stock out during the COVID. And the second line and first line medication, there hadn't been general issues. The only issues were the adolescents and children going to the facility to get the medication. So the medications were not short, they were available, but accessing them was the problem because of the notion that there shouldn't be any movement over the COVID period.
Okay, thank you. Thank you. I think that Dr. Martinez is ready now.
Good afternoon. Can you hear me now?
Yes, we can hear you.
Okay.
Okay, yes. Okay, Anthony, you can introduce her. Go ahead.
Do you want me to share your slides, Celia, or do you want to do it yourself?
Please, share me, please.
Okay, it's coming. 1 second.
As I said earlier, because of time, we will let Celia Martinez, who is with Powerful Child and Adolescent TB Working Group, give us her lecture. Go ahead, Celia.
Okay. First, I want to thanks for the invitation to participate in this meeting, and I want to thanks to Anthony and Codwell. COVID represents the next, please. The next, please. COVID-19 represents a massive the previous. The first, please. The first slide, please. Yes, okay. COVID represents a massive health, social, and economic shock with an immense human toll for the countries of Latin America and the Caribbean. These two documents present the impact of the COVID pandemic in Latin America and the Caribbean. The next, please. Several Latin American and Caribbean countries show how of the highest number of absolute and per capita cases worldwide. With fragmented and unequal health system, they are ill-prepared to handle a health and human crisis of this scale. Participation in health insurance plans was low. Lack of access to quality health care and information is especially acute in rural and remote areas, affecting particularly indigenous peoples. The next, please. The Economic Commission for Latin America and the Caribbean projected a 5.3% drop in GDP and 1.6 million more unemployed in 2020 compared to 2019. In 2020, poverty in Latin America may rise by at least 4.4%. About 28 million more people comparing to the prior year. The next, please. As you can see in this slide, the Economic Commission estimates that around 10%, about 11 million people were living in non-extreme poverty in 2019 are expected to fall into extreme poverty. Similarly, 15% of those in low-down poor strata are expected to fall into non-extreme poverty, about 20 million people, or extreme poverty, about 3 million people. The next, please. The debt crisis of the 1980s led to very significant increases in poverty levels. It took about 25 years for the region to return to the pre-crisis poverty levels. It is important to review these events because the increase in poverty projected by Economic Commission for 2020 signifies a 13-year setback for the region. The next, please. In this slide, we can see that the population most affected by the socioeconomic impact of COVID and its population includes children and adolescents. Children and adolescents has been affected by closure of schools. The healthy development of children and adolescents is at risk. If school feeding programs are not maintained, the nutrition and diet of the student population in the most vulnerable sectors will be deteriorated. The next, please. The pandemic is exacerbating existing food insecurity. Latin America and the Caribbean has been an almost threefold rise in the number of people requiring Food assistances. The number of people undergoing acute food insecurity could increase by 11.7 million to 16 million people in 2020 because of the pandemic. Also, the Gini index is expected to increase with the pandemic by between 1.1% and 7.8% in several countries in the region. So, the increase in poverty and extreme poverty seriously undermines the possibility of ending poverty in all its forms everywhere by 2030, and to wider extend the possibility of achieving all the targets relating to the social dimension of the 2030 Agenda for Sustainable Development and also the targets of the NTB strategy. The next, please. But how COVID-19 pandemic impacted TB programs in the Americas? Outpatient services were partially interrupted. These interruptions have affected all types of care for people with TB. Routine health services were reorganized or interrupted, and many stopped providing care to people in detection or treatment for TB. Diagnosis was interrupted because the laboratories don't have the biosafety cabin or adequate personal protection equipment to following the recommended safety measures. TB health services were organized or interrupted, and many stopped providing treatment. Many of the healthcare workers who usually provide TB care were assigned to the COVID response. Fear of the population due to the probable transmission of COVID-19 in the health services. The next, please. Next, we are going to look at some examples of the impact caused by the pandemic. In this slide, we can see the impact of COVID-19 on the monthly notification of TB cases. This is a preliminary information for 10 countries from January to June 2020 in all countries. And in all countries, we can see a decrease in the notification of TB cases in the months April, May, and June, with a total decrease of 40% in all countries. The next, please. Also, to evaluate the situation, we compare the first semester of the year 2019 and 2020. And here we can see the number of pulmonary TB and extrapulmonary TB cases identified in children and adolescents between January and June 2019 and 2020. And we can see in Mexico a decrease in 19 and 24%. In Cali, Colombia, decreases of 32 and 56%, and in Paraguay, 29 and 21%. The next, please. Also, percentage of TB cases identified in children and adolescents with no HIV status decreased. In Mexico, decreases 13%, and in Paraguay, 10%. Next, please. The number of children and adolescents on IPT also decreases. In Mexico, 55%. In Cali, 63%. And in Paraguay, 21%. The next, please. And the number of household contacts, children and adolescents investigated decreases. 47% in Mexico, 56% in Cali, and 65% in Paraguay. The next, please. In Paraguay, the impact of the pandemic was observed in the entire population, including the indigenous population of the country. We can see a decrease in the detection of TB cases in March, April, and May. With the intervention, we can see an increment of the TB case detection in June. The next, please. After the declaration of the COVID pandemic, the PAHO WHO prepared an informative note on tuberculosis and COVID. The objective of this note was to assist national TB programs and health personnel with ensuring continuity of essential services for people affected with TB during the COVID pandemic. Another document is the guideline for laboratory diagnosis of TB during the COVID pandemic. The next, please. PAHO WHO also prepared information material for the population, which is available on the PAHO website. The next, please. And what did the health ministries do? They elaborate operational guidelines on maintaining TB health during the COVID pandemic. Guidelines on how to provide continuity for TB program, how to provide medical care for TB, telemedicine, and BRT, communication materials, education campaigns for the population, COVID transmission and biosecurity, campaigns targeting healthcare workers, and how to provide TB care in the health services. The next, please. Also, national TB programs also provide technical assistance to health services and local TB programs. A strong coalition with civil society organizations, scientific societies, indigenous health sector, parliamentary fronts, and communities monitor the access to and continuity of essential health services for TB, coordination meetings with the laboratories, and psychosocial support for patients with drug-resistant TB and at risk of loss of follow-up. The next, please. And here we can see some examples. In Brazil, they elaborate guidelines to management and control of TB during the COVID pandemic and information for the community, frequent answering questions, information about social protection for TB patients during the COVID pandemic. The next, please. In Peru, the main objective of the health intervention was the timely detection of tuberculosis cases to guarantee treatment. The national TB program prioritized the TB contacts, people living with HIV, diabetes, and children, among other vulnerability factors. The community activities were coordinated with the civil society organizations for TB prevention counseling, detection with CHIS radiography, and gene expert. The next, please. The COVID pandemic changed the way of providing TB treatment. The national TB program in Peru implemented the BOT. Also, in the web of the Ministry of Health, we can find information about treating TB and COVID in jails, prevention, TB in children and adults. The next, please. Some countries like El Salvador, Honduras, and Colombia also elaborated guidelines to ensure the TB integrated patient-centered care and prevention, with early detection, treatment, and prevention for all TB patients, including children. The next, please. Paraguayan Ministry elaborate guidelines with the objective to guarantee the TB detection in the general and indigenous population, persons in jails, and other vulnerable population, including children. Next, please. In Paraguay, civil society and the National TB Program work together to active case finding and contact tracing in jails, advocacy for laboratory reopening, delivery of food baskets for drug-resistant TB patients, and patients living in rural and indigenous communities, household and community-based care. In the picture, you can see the healthcare workers going in a small boat to an indigenous community to follow up cases and contact tracing. The next, please. In Mexico, they elaborate information for healthcare workers, guidelines on management and control of TB during the COVID pandemic, and also information for the community. The next, please. On the other hand, the coalition with civil society organizations play a very important role in the fight against TB, helping to integrate the community-based TB activities with the health services and the local TB program. The civil society organizations work in the community to deliver drugs, take sputum samples in remote communities, in indigenous communities, and in jails. Contact tracing and household and community-based care. The next, please. The pandemic made it more difficult to access for people, especially the poorest and the most vulnerable people, to meet their basic needs. It is therefore necessary to guarantee income, food security, and basic services for a large group of people who have been rendered extremely vulnerable and who were not necessarily included in existing social programs before the pandemic. Countries have adopted measures that mitigate and reduce spending by individuals and families. By April 2020, 22 countries in Latin America have announced 45 additional measures, of which 60% are credit and mortgage payment facilities, 22 are tax relief, and 18 are price control. So, as you can see in the slide, in the presentation, some countries have pre-existing conditional cash transfer programs with a coverage between 10 and 26% of the population. The next. And some countries implemented temporary transfer programs with a big coverage of the population in some countries, as you can see in Guatemala and Peru, or have adopted economic support measures for healthcare workers who are at risk of infections. The next, please. Finally, we can conclude that countries and the National TB Program have made numerous efforts to continue the fight against TB in the context of the pandemic. TB capacities building contribute to the response to the COVID-19 pandemic, mainly in relation to search and contact tracing, home and community-based care, as well as in surveillance and monitoring system for TB. The action incorporated to address COVID-19 can benefit the programs, especially in relation to infection control and telemedicine. And it's necessary to guarantee income, food security, and basic services to a large group of people who has become extremely vulnerable. Thank you very much. And I want the next, please. And I want to thank to Bettina, Manuela from Colombia, Lucy, Elsa Camilo, Sarita, Zulma, Marta Angelica from Mexico, and Rafael Lopez and Pedro Abedillo from Bajo. Thank you very much for your attention.
Okay, thank you. Thank you, Dr. Martinez. We'll take the last speaker, Ms. Rabat Mwaniki from Kenya. She will share with us the community perspective on COVID and TB. Over to you.
Kopto, I'm not entirely sure if Rahab is online.
Okay.
She sent a message that trouble. I saw her coming in and out. So I'm not sure if she's able to give the presentation.
Okay.
I don't see her in the list right now.
Yeah. Okay. So maybe what I can put one comment regarding the community. So what we can see with the two presentations is that we have a real impact of COVID on TB services and child and adolescents TB services too. And it's important, I think, to highlight one negative element, management of TB, the community. So unfortunately, she can't share. She's not there to share with us, but we can say that local and non-government as well as other civil society organizations have historically been neglected in the TB response, and yet they can play a vital role to support TB. Effective communication about TB and COVID-19. And in the last presentation, Dr. Martinez mentioned many roles that a community can do to help a TB program. So they can sensitize community to continue to attend health service. I don't know if my co-chair want to say something. If not, we will take a question for and also for the previous. Thanks for this.
Yeah, thanks very much.
Yeah.
For again, it would have been interesting and would have added on to the perspective if you got to know what the community challenges with COVID and TB was. Of course, having said that, most the conditions we see in the hospital are reflections of what comes from the community. And depending on the level of lockdown and the level of arrangement by the national TB programs, there could potentially be general radio and the TV interventions which could have informed how people will behave, as well as teaching them opportunities to access care if the need rises. But I agree with you that the perspective of the last speaker would have been of great help if we had been able to join and told us about the things on effects of COVID and TB in the community perspective. And for now, we probably need to go on opening and opportunities to respond appropriately, likely from outstanding questions as well, because probably there were questions that came up from the earlier sections, but because of time, they couldn't pick up the question. So we can make room for general questions and comments on all that has been said so far. Thank you.
Thank you very much, Kopto and Animila. Sabina, have you been in touch with Rahab?
She hasn't responded to the email, and I saw her during Celia's presentation. I saw her coming in and out, but she's not online right now. So I'm afraid that's not going to work.
It seems the connection is a bit more difficult this afternoon than it was this morning, and we apologize for that. It's probably a number of people using internet at the same time. It is almost 5 o'clock. I'm not sure if Farhana is still around.
I saw Farhana coming back as well, but I'm not sure.
I'm here.
You're here.
So yeah, I caught some of the talks, and I'm really happy that I was able to. So yeah, and really thoroughly enjoyed whatever I could catch of the second half. So I guess should we be closing, considering that Rehab is not is having probably having some internet issues and may not be able to deliver her presentation.
Yes, it's unfortunate. Please go ahead, and then afterwards I'll say a few things on behalf of the Secretariat.
Okay, wonderful. Thank you, Anamika. I just want to say what a pleasure it's been to have attended and participated in today's very rich and robust meeting of the Child and Adolescent TB Working Group. We had the first half was mostly updating you on the activities that the Child and Adolescent TB Working Group has done, catching up on that, as well as the WHO updates, and especially the big highlights of the Global TB Program, the Global TB Program 2020 TB report. So that and with some very good things, but also some sobering information, and all the work that needs to be done, and the regression that we are likely to note perhaps in next year's report, will be reflected in next year's report. And then we had the excellent TB research updates from the SHINE TB trial, as well as the TB meningitis work that Karen Dupree's presented, and the Annika's talks are always very enlightening. And of course, James went over some wonderful papers. I think some I hadn't actually noticed till James highlighted them. So that's always a welcome session. For in the second half, we had I missed the session on the one that Maureen and Lisa chaired, and so I can't say much about that. But I'm sure I would love to. I'm going to go back and listen in and attend the and check out the session that has been recorded. But I did happen to catch Leo and Brian's talks in session 2B, chaired by Lindsay and Susan Maloney, and it was again a wonderful systematic reviews, very very informative, and really excellent information that will hopefully help us going forward. And the session 2C was I since after the webinar that we had. So I'm familiar with this information, and it's very, very, again, sobering, but also enlightening of how the NTPs and the programs have had to repurpose activities during the time with the COVID crisis. And really, the community work that Celia was describing was, as usual, it was great to see that sort of those efforts. Unfortunately, the video you were not quite able to enjoy for the event. We tried again, but that didn't work. But hopefully, there will be some sort of a link that we can share at some point, and you can enjoy that or rather review it at that point. So having said all that, I really want to thank all the speakers, all of you that attended, and all the robust discussion in the chat that was going on. And it's just so wonderful to see all the excitement and energy around childhood TB, and now and finally we're getting to the adolescents now. Well, we hope to see you in the union sessions. We've got plenty on children, and there's some symposia as well, and hope to run into some of you there. Thank you very much once again, and over to Anamika and Sabina. You guys have had a very long day. Thank you again for organizing such a wonderful, wonderful meeting. Really, over to you guys. Thanks.
Thank you very much, Farhana. And then also on behalf of the Secretariat, we would like to thank all the presenters as well as the chairs and all the participants for a very interesting and rich day this morning as well as this afternoon. And I've seen that some of the participants based in Philippines, Indonesia, India are still around. And this morning we also noticed that colleagues from Brazil and some colleagues based in the US were already up very early to attend the morning session. And it's very heartwarming. Again, apologies to Bettina and Andrea for the technical hiccups. Sabine and I try hard with technology, but it doesn't always work out. I think we need younger generation to convene it without the technological issues. Regarding the data in the Global TB report, indeed, it's good that we are refining our data set, but what comes in is sobering, and even more so because the data you've seen today, this morning, are actually over 2019, before the COVID pandemic set in. So we're really worried what we will get for next year's report. And we hope we can still turn around the tide. At the same time, we heard about shortages of new innovations such as rifapentin due to the impurity issues. We wanted to also highlight that even though it is a fantastic future regimen to prevent TB in children, it's also important that we use what we currently have. And for many children, 3RH and dispersible INH are available and should be implemented as soon as possible. Do not wait until issues have been solved. Thank you very much to the SHINE team for sharing your important results prior to the union conference, and also thank you for the union conference organizers to allow that. we see encouraging emerging experiences with new diagnostic approaches. And I think what Leo Martinez highlighted is that children above 5 are still likely to develop TB disease, makes the case for expanding TB preventive treatment in children household contexts 5 years and above. Thank you, Brian, Anna Mandalakas, Karen Steingart, for the hard work you're doing on this and have completed on the systematic review of screening approaches. And we're really looking forward to look at the findings again beyond the screening guidelines. The impact of COVID is massive all around the world, and thank you very much to the presenters to share their experiences both in Africa and the Americas. Thank you, Anthony, for mentioning the role adolescents play as well in addressing things. The pandemics also have led to some opportunities to addressing TB and COVID at the same time in terms of simultaneous contact investigation and scale up of shorter TPT regimens, introduction of all oral regimens for children with drug-resistant TB. We know that we have digital technologies that can be used to reduce in-person visits and follow adherence. And of course, national TB programs and partners working on TB can do a lot about infection control. Today's virtual meeting does by no means replace a face-to-face in-person meeting, and we sincerely hope that we can organize a face-to-face meeting next year. But we greatly appreciate your flexibility, and the Secretariat would also like to warmly thank USAID for the continuous financial support and technical support. Without that support, we wouldn't be able to take the activities of the working group forward. And as usual, we will make the presentations and a meeting report available as soon as possible. But please give us a little bit of time because also the union conference is coming up, and I hope many of you will be having an opportunity to participate in the union conference. We would like to wish you all a good continuation of the day, and please stay safe. So best wishes from all of us. Looking forward to the next year, and to work together and push the agenda forward. Thank you very much.
Thanks everyone for a lovely meeting.
Thanks, Sabina.
Keep in touch.
Thank you.
Thank you
Bye.
very much.
Thank you. Bye-bye.
Thank you.
Bye.